Hi, my name's Tiffany, and I am the Perinatal Education Coordinator here at Liberty Hospital. And we have put together a little presentation for you um, to help supplement any learning for the upcoming birth of your child. Since we cannot have in-person classes right now, we have chosen to show you this PowerPoint and talk to you about each of the slides, just like we would in an in-class or in-person class. Hopefully this helps you to be able to go through this PowerPoint at your leisure whenever you need to, so you can stop it and start it whenever is convenient for you. At the end of the PowerPoint, I'll have my email address up so that you can email me any questions that you might have when we're done with this. So just to get started, our class mission is to learn about childbirth topics in a fun, comfortable, and respectful class environment. Knowledge is power, so reaching out and getting the most knowledge that you can, the most education that you can about what is normal so that you're not worried about the normal terminology is very important. A lot of times people get worried about what we're talking about. Is that normal? Is it not normal? And it might just be something very normal. There's nothing wrong, but then they might have anxiety about it because they don't know what that is. So having the most knowledge is very important. And attitude is everything. So if you go into this experience thinking that this is going to be the worst experience of your life, then it's going to be. But if you go into this thinking, this is the birth of my child, I never get to do this again, this is a gift, it's an opportunity to bring a new life into the world, then things go a little bit more on the positive side. Think of it as this is not a death sentence. It's not a terminal illness. This is something that is chosen. This is something that that you never get to do again. So think of it that way and have a good attitude about it. This is just something that's kind of fun. Your baby can see light through the stretched out skin. He can probably tell the difference between night and day. All right, and here's just a little video.
Pregnancy lasts about 40 weeks and is divided into 3 trimesters. Let's focus on the 3rd trimester. It starts at week 28 of your pregnancy and ends with the birth of your baby. During these final weeks, your baby continues to grow and develop. When you are between 39 and 41 weeks, your pregnancy is considered full term and your baby is ready to be born. If you haven't had your baby by 42 weeks, you're considered post-term, which is also normal, but your healthcare provider will probably keep a closer eye on you and your baby. 4D ultrasound images like this one give us a glimpse at what babies can do during the 3rd trimester. As this baby rubs her eyes, you'll see that she already has her own unique facial features. In this next ultrasound, watch as she licks her arm. These mouth and tongue movements help her learn how to feed. And here, she's practicing how to move her hands and fingers. While it looks like your baby is ready to greet the world, he needs a little more time. Babies born from the 37th week to the end of the 38th week are considered early term. Early term babies are still at a greater risk for breathing, feeding, and other medical problems. It's usually healthiest for the baby to be born at 39 weeks or later. During the final trimester of pregnancy, your baby's brain continues to develop. In fact, it practically doubles in size and adds brain cell connections needed for balance, coordination, and learning. Also, your baby's lungs are still forming, and he's gaining the fat that will help him stay warm once he's born. So even though you may be uncomfortable, Be patient. The health of your baby is worth the wait.
So interesting.
All right. So that video basically talks about the last few weeks of development and how important those last few weeks are. A lot of times people think that being full term or being 37 weeks, but there's still a lot of development going on. So next we're just kind of talk about the pregnancy anatomy and the changes that are happening within your body. Some of you guys have probably noticed some of these already, but as we kind of move on, I'll kind of talk about a little bit more of it. These different changes that are going on within your body. The first thing I kind of like to talk about is what I feel like is the most obvious is the size of the uterus. So here is the uterus, the non-pregnant uterus, down here on the little orange organ. And here is the pregnant uterus, all right? So it's very important to understand what the uterus is. The uterus is actually a muscle that stretches to hold the pregnancy, okay? So it is a muscle that holds the pregnancy. So when we are talking about the uterus, I want you to think about that it actually is a muscle. So think about that in terms of that it is a muscle. So it is obviously very stretched out. There's also these ligaments right here. And these ligaments actually also stretch to hold up the uterus and do not grow. So a lot of times when people are going through growth spurts in their pregnancy, then a lot of times they will feel pulling or tugging on one side. Sometimes people feel like they're actually going to rib. I've had people say that, and I felt that myself during pregnancy. And that is the uterine ligaments that hold up the uterus right here. Those are called round ligaments. Another thing to point out is your intestines. So your intestines right here and then here are obviously very smashed, for lack of a better term. They are smashed up and pushed up into the lungs, into the chest cavity, and causes a decrease in lung capacity that is also noted here. So here's your lungs, and you have smaller lungs here because of your intestines being pushed up, and then the intestines are pushed up into the chest cavity and decreasing the size of your lung capacity. As you might notice, as pregnancy gets bigger, that you feel like you can't take a deep breath. And that is because of the lung capacity has actually decreased, the size of your lungs. Luckily, your blood, you produce, you actually make almost twice as much the amount of blood that you need in pregnancy, which also means that you have extra hemoglobin, which carries extra oxygen molecules to all the different parts of your body also. So you do kind of compensate for that. Another thing to note is your bladder. So the size of your bladder. So this is your bladder, and this is your pregnant bladder. I like to show it with the baby inside. Let me kind of get to that. All right, so there's a picture with the baby inside, because I feel like it actually looks even smaller as the pregnancy gets larger, and as you get closer to your due date, your bladder capacity definitely decreases because the baby is definitely pushing into that space. So then you go to the bathroom more often. Another thing to note is that as your pregnancy also is farther along. A lot of times before that baby actually drops into the pelvis, a lot of times people feel like they can't eat as much. They're still hungry, but they can't eat as much, so they eat smaller, more frequent meals, and that's because of the size of their stomach. So their stomach size is decreased also. And that also causes some issues, maybe even with reflux or heartburn. That's why a lot of pregnant women have that, is because of having that decreased space and having everything kind of being pushed up at the end. Other notable changes are the size of your breast. And we already kind of talked about the diaphragm is actually right by the stomach, and that actually causes the decrease in the lung capacity also. All right, so what is your uterus? All right, so I already kind of talked about it a little bit, but it is important to understand what the uterus is. So your uterus is a large muscle that stretches to hold the pregnancy and contracts to deliver the baby. So when you think about a muscle, muscles contract, right? They contract, they tighten, and that's what your uterus does. It actually contracts and helps to deliver the baby. What's your cervix? So your cervix is located at the bottom of your uterus, and that actually is the opening. So your cervix actually opens, which is to dilate, and thins, which is to efface, which we're going to talk about even more on the next couple slides. So at the bottom of your uterus is your cervix, all right, and that is actually an opening that helps to deliver the baby. So this is just showing the uterus actually contracting. So what I want to point out here is at the top of the uterus, where her hand is located at, is that the uterus is actually contracting. It's actually getting tight and is pushing the baby down. So kind of let me show you what I'm talking about here as it's playing. So this is, so right here, this is the baby, this is the uterus actually tightening and pushing that baby down. Also look at the bottom by the baby's head. That's going to be where the cervix is located at. All right, so talking some more about the cervix. This is more information about about your cervix. So your cervix does a couple things. It will actually get thinner as labor progresses, which is to efface. So to efface is what is to thin. The goal with effacement is 100% effaced. So we do effacement in percentages. So this first picture that I'm going to show you is a uneffaced cervix, is what we would call it. This is a thick cervix. This is uneffaced. Okay, so right here, it's very long, so long this way. All right. And so if I were to put my finger into this opening right here, that would be about the length of my finger, which would be a very thick cervix, and we would say that is 0% effaced. On the other hand, if I were to put my finger into this cervix right here, see how short that is, this I would say is probably maybe 90% effaced, so it'd be about 90% gone. So maybe only 10% of this cervix right here is left. Okay, so this is about 90% effaced. So the difference in the thickness is what we're looking at here. All right, does that make sense? Okay. And then next we'll talk about dilation. So dilation is to open. So open. So on our, we'll continue to look at our previous pictures. And this cervix is not open very much at all. Okay, see, this just got a little bit here. And so that may not even be able to get one finger in. How we measure dilation and effacement is we use our fingers. Dilation is measured in centimeters, and most people who examine cervixes know how wide their fingers are. So most of us, our fingers are about a centimeter in width. So one finger breadth is about 1 centimeter, and so on and so on. Our goal with dilation is 10 centimeters. So this, let's say this right here, cervix might be, let's go with 1 centimeter for that. And then let's say this is 2. So let's say I could fit 2 fingers here side by side, and this would be 2 centimeters in the next picture. Okay. So that is to dilate or to open. All right, so 10 centimeters is our goal with dilation. You might also hear us say, as you reach 10 centimeters, that it is completely effaced. So sometimes people will say that they're complete, and that means that we don't feel any cervix left. We only feel presenting part. So we only feel that baby's head. The cervix is completely gone. That is completely dilated. All right, so here it is again. The dilation is measured in centimeters. So it goes from closed to 10 centimeters. So closed would mean we cannot get a finger into the cervix at all. And 10 centimeters or complete, there is no cervix left. We don't feel any cervix. The effacement is measured in percentages. And this would mean that we only feel a thick cervix, which is 0% effaced, would be like the length of our finger. A paper thin cervix or 100% effaced cervix would be feel like literally like a piece of very thin paper, and that's all that we can feel left on our finger. So it's very sometimes that is a very hard cervix that we can just barely feel the edges of it. Station. So we haven't talked about station yet. So station is where the baby's head is located in relationship to your pelvis. So how low the baby is. Has the baby dropped? You might hear people say that. And we can feel your ischial spines when we are also checking your cervix. And those are bony prominences that we can actually feel. And when the baby's head is equal to those bony prominences, then that is 0 station. All right, and we'll show another picture about that, kind of help you with that. So 0 station is when the baby's head is equal to those bony prominences. So these are the bony prominences that I'm talking about. Sometimes when you talk about people having a bony butt or something like that, then those are what you're feeling when that your bony butt. Those also people that do yoga, you'll hear them talk about that you're on your sitting bones. So those are your sitting bones. But those, and when the baby's head is equal to that, that is 0 station. Anything above that, so anything up here is in the minuses, so minus station. So -1, -2, -3, -4, -5, okay? Anything below that is in the pluses. So here in the pluses. So anything below that is in the plus station. Let me go back, sorry. Okay. So that is station, where the baby's head is in relation to your pelvis. So when we're actually doing a cervical exam, we're actually feeling for many things. We're feeling for dilation, how open the cervix is, effacement, how thin the cervix is, and station, where the baby's head or presenting part is located at in relationship to your pelvis. And then of course, we're always feeling for, is it a head or what is presenting? Is it a butt? Is it something else? Can we also feel a bag of water? So there's a lot going on when we're actually checking your cervix. It's more than just actually checking your cervix. Okay, so I always just like to talk about this in class, when to call your doctor. So these are things to call your doctor about. If you're having vaginal bleeding that looks like a period, that is never normal in pregnancy. That would be a good reason to call your doctor. A fever over 100.4, pain or burning with urination, that is not normal and that is not labor. That is probably a urinary tract infection that pregnant women are really prone to. And you would need to get treated for that. Sudden swelling in your hands and face. And so swelling is something we talk about a lot. So swelling in your feet, if you've been on your feet all day, or even if you've been sitting all day, swelling in your feet is somewhat normal in pregnancy. But swelling in your hands and face, even after a good night's rest, is usually what I tell my patients. So even after a good night's rest, so this is after you've slept all night and you still have swollen hands and feet. That's not normal. So that would be a reason to call your doctor. Problems with your vision or recurring headaches. So the problems with your vision, those would be like spots before your eyes, a part of your vision field that you can't see. You might feel like you can't see out of one eye. Those would all be reasons. Or a headache you cannot get rid of with Tylenol. All right, if you can get rid of it with Tylenol, it's probably not that serious. But this would be a headache that you would not ignore. This is a serious headache. That would be a reason to call your doctor. And both of those things, the sudden swelling in your hands and face, and then problems with your vision, those are both, we're worried about your blood pressure. So we would definitely want to have that checked out. Vomiting or diarrhea lasting more than 24 hours. So what did I already tell you? What is your uterus? It's a muscle. What happens to muscles when they get dehydrated? They cramp, okay? So we need to keep your uterus and the rest of your body hydrated, or you're just going to generally feel uncomfortable. You're gonna have cramping, contractions, and it's just from being dehydrated. Major changes in your baby's movement. So you know how your baby moves. You know what's normal for your baby. You know when they're active, when they're not. But if you just don't feel like your baby's moving around as much as they normally do, then you can do a kick count. And what that is we want to make sure you've eaten, because babies do like food. Make sure you've drank. You're gonna hear me talk lots about drinking water. So make sure you've drank at least 8 to 10 glasses of water a day. Okay, so that's how much you need to be drinking to stay hydrated. And anything that you choose to drink that's caffeinated, the caffeine actually dehydrates you some. And so whatever you drink in a caffeinated drink, you need to add that amount onto your 8 to 10 glasses of water a day. So if I had a 12-ounce soda, I would need to drink an additional 12 ounces of water to make sure that I stay hydrated. All right. So to do a kick count, make sure you've ate, make sure you drank, and then do nothing but lay and count how many times your baby's movements. Most doctors say that they want your baby to move 10 times in 1 hour. If you lay there and your baby moves 5 times in 5 minutes and you feel like they're moving fine now, you don't have to lay there the whole hour. You know, sometimes babies also go through sleep cycles, and they'll go through a 30-minute sleep cycle. So sometimes you do have to count for a little bit longer. Sudden pain in your abdomen, not normal, not labor. Okay, so anything, labor is not a sudden pain. Labor is not a sudden sharp pain. Labor is gradual. It comes on over a time period. It is not something that it just is hits you acutely. So that is would be a reason to call your doctor. So preterm labor. Preterm labor is before 37 weeks. So these are some signs of preterm labor. Any change or increase in your vaginal discharge. Okay, so all of us ladies, we know what's normal for our vaginal discharge. This would be different. This is not what you've been having for the last, 2-3 months of pregnancy. This is something that's different. This is a change, okay? Same thing with pelvic or lower abdominal pressure. This is not the pelvic or abdominal pressure that you've been having just because you're pregnant. This is a change. This is something that's different, that you're feeling something different than what you normally have felt. You're a constant low or dull backache, or sometimes it feels like it's coming and going, which would be contractions. So sometimes you feel that in your back. Although if you feel your abdomen, if you feel your stomach, then it actually is tightening. So that would be something definitely to kind of keep track of. The mild belly cramps, that's more like menstrual type cramping. You feel like you're having menstrual type cramping. Sometimes it comes and goes. Sometimes it seems like it's more constant, but definitely something to pay attention to. Or you feel like your water breaks, can be a slow trickle or a gush. And we'll talk about more about your water breaking later. But anytime you have any questions about your water breaking, you need to have it checked out. That is something that we don't want you to ignore. We want to confirm yes or no, is it your water? So contractions, if you feel like you're having more than 4 in an hour, that would be a reason to call the doctor. You can have some, and it's just your body's way of kind of a pre-workout to do that. Anytime you might be feeling some of these, pay attention. Do they have a pattern? How many are you having? Are you just having one a day? Fine. Or are you having multiple in an hour? So that would be the reason to start paying attention. Also, you want to make sure that you've ate and drank. So a lot of times your uterus will contract or give you and cause you to have undue pain because you're dehydrated and it's cramping. So always rule that out. Make sure that you're hydrated, okay? To kind of do that. Some other things to help rule out preterm labor risk, go to your prenatal appointments, prevent infection. So that's why we've all been in quarantine, that we are keeping ourselves isolated and trying to decrease the risk of us having an infection. Use good hand hygiene, use good dental hygiene, stay away from people that are ill, and of course then reduce the amount of stress in your life as much as you can. But it never fails. There's always somebody in class that they're building a house or moving that at the end of their pregnancy. So, but try to reduce the amount of stress as much as you can in your life. And that will help you. Trust your instincts. If you feel like something's wrong, call your doctor. We would rather you call and us tell you everything's fine than you not call and we wish that you would have. So err on the side of caution. And speaking of that, do you know how to get a hold of your doctor? Do you know how to get a hold of your doctor after hours? Do you know when they want you to call them? Those kind of things. So that would be definitely something to talk to your doctor about. Most of the physician offices, if you call the doctor's office, you stay on the line. There's an answering service that actually picks up after hours, and they write down your information and they page the doctor on call, and then the doctor on call calls you back. So that is how you usually get a hold of them. But make sure that you've talked to your doctor, and so that you know how to get a hold of them. All right, just another little fun fact. The placenta and the umbilical cord pass oxygen, nutrients, and other substances from your blood to the baby. So everything that baby gets is through that umbilical cord and that placenta. Everything has to cross through the placenta and through the cord to get to that baby. So your baby does not breathe while they're in utero. Their lungs actually are not functioning. They get the oxygenated blood from your blood and goes to them. So their lungs, like I said, is not actually functioning. So whatever you take in, if it's not something that you would give a baby, maybe you shouldn't take it in. So just something to kind of think about. Right? So here's just a little laugh break about our babies and and every pregnant woman learns where every bathroom is, and any significant others learn how to stand outside the bathroom and wait. That's kind of always my ongoing joke. So your body knows how to do this, so trust your body. All right, so let's jump into labor. All right, so we're going to learn about labor and what causes labor pain and how labor progresses. So what I want you to do is I want you to think about what experiences you've had with pain. Some of our patients have not had many experiences with pain, which is great because we have healthy patients. They may never have had a surgery, never really had a broken bone, really nothing. So it's really hard for you to judge what experience you have had with pain. But if whatever experience you have had, how did you deal with it? Are you somebody that absolutely, I don't want to be touched, don't touch me? Or are you somebody that wants support and wants to be touched? So think about that. That might have a little insight on how you might be during labor. And what ways do you imagine that labor pain will be different? The good thing is with labor pain is that it does come and go. So you do get a break. That is the positive thing, so that you can recuperate in between. Now the breaks are not very long, and you have to use your breaks wisely, would be my advice to you. All right, so kind of think about that and talk to whoever's going to be your support person about possibly how you deal with pain, and be open and honest about it. So the pain of labor has a purpose. It is not just because, it has a purpose. It's to deliver the baby. It's anticipated. That can be good and bad. So anticipated. So you know it's coming. So sometimes that causes anxiety because you know it's coming. But the other thing is that's good is that it's anticipated is that you can plan for it and possibly learn how to deal with it and have some practice time. It's intermittent, like I already said, it comes and goes. So that is definitely a positive. It comes and goes so that you do get breaks. It's normal, right? Labor pain is normal. It is, again, it's not a chronic pain and it will end. That is one thing I can tell you. The baby will be born. There's not a lot of things that we can promise you in the labor world and the OB world in general, but the one thing that we can say is the baby will be born. Sometime, somewhere, somehow, the baby will be born. I don't know when, I don't know how, but that's about the only thing. There's not a lot of black and white things. And sometimes that is scary for people, especially my type A people, that they want to know, they want to have it planned out. So it is sometimes hard to know, but just to kind of let down your guard and just trust that things will happen. So the 4 P's of labor, all right? So this is just kind of a way to remember that there's multiple kind of parts to labor. The passageway, so the passageway pelvis. So that's how the baby gets out, the passageway. The passenger is actually the baby, all right? So the baby. And a lot has to do with the baby. Has to do with their position and kind of how they're coming down into that passageway, into your pelvis. The power, that is the uterus. The power is the uterus and that strong muscle that will contract and push the baby down and out and help deliver them. And then your psyche. So how you choose to deal with this. Are you choosing for this to be the worst experience of your life? I hope not. We want it to be the best experience of your life. So we want you to have a relaxed, positive attitude going into this. So talking a little bit more about the passageway. So your pelvis, if we all had pelvises like this, our life would be, labor life would be great because this pelvis has plenty of room in it. So here is our pelvis. Here are those bony prominences right here. So if our baby's head is equal with that, that's a 0 station. So this is mom's front and this is mom's back. So this is, let's say this is your tailbone right here, okay? So just to kind of give you some landmarks. This baby is looking face down, and I can tell that because of the way the fontanelle is. The fontanelle is the baby's soft spots right here, okay? The baby actually has 2 fontanelles, all right? The anterior and posterior fontanelle. All right, and so as other things to talk about is that your baby actually comes down into the pelvis looking to the side, and that's normal. So I'm going to go back to this picture here. This baby is looking straight up and down. Sorry, keep doing that. Eek. All right, so this baby is looking straight down. So the babies can either look straight up or straight down. Sometimes they're looking to the side, but as a labor progresses, they come into the pelvis looking to your side, and then their head rotates, whether to look up or down, and then they are delivered. As they are delivered, as we'll kind of see in this video, the baby will extend their head and then choose to look to one side or the other, and then they're delivered on their side. So I kind of want to just talk to you about that. All right, so here's the baby looking face down. They come out from underneath the pubic bone and extend their head. And then with another contraction, then they rotate looking to one side or the other, which we never know which side they're going to look to. And then the rest of the baby's delivered, and they're actually delivered on their side. Okay. All right, so that's actually called the cardinal movements. So here we're going to kind of look about the different positions of the baby's head. So baby's head looking face down is the anterior position right here. All right, so baby's looking face down or toward your back, which is actually our goal. We want them to look face down. The diameter of their head is smaller when they're looking face down, and they're able to, once they get underneath the pubic bone, extend their head and their neck once they get underneath that. The other position that the babies can be in and that they're delivered every day is the posterior position. So you might hear us talk about the posterior position or facing your back. Some people say sunny side up or OP. It's occiput posterior, so the back of their head is facing the mom's posterior, their mom's back. Like I said, babies can be born like this every day, but the diameter of their head is a little bit wider, and you can almost see that right here. See, the diameter of the head is a little bit wider compared to here. All right, so once they get underneath the pubic bone, they're not able to extend like they could if they were looking down. They can extend their neck up and out, kind of like you think of like an animal or a giraffe. Like I always kind of think about it as a turtle extending their head out from underneath their shell. All right, so here's some little videos about the anterior and posterior rotation.
As active labor progresses, the baby starts a process called internal rotation, which positions her head for birth. Usually, the baby's head turns so she is facing her mother's back. This is called the anterior position and allows her to more easily.
Sorry about that. Let's try that again.
As active labor progresses, the baby starts a process called internal rotation, which positions her head for birth. Usually, the baby's head turns so she is facing her mother's back. This is called the anterior position and allows her to more easily fit through the pelvis and into the birth canal. In some births, the baby's head turns so that she's facing her mother's front. This is the posterior position. In this position, her head puts added pressure on her mother's back, which may cause back pain and slow down the labor.
You want anything?
With her mother's support, Nakaya has been in labor for 8 hours. She tries certain labor positions, like leaning forward on her hands and knees, to turn her baby to the anterior position. This also helps relieve some of the pressure against her back.
There was a point in my labor where I was on the exercise ball and I was doing a different position, like laying on the bed, to help me take my focus off of the pain and onto other things.
All right, so that has a nice little video about the anterior and posterior position. Also talks about different positions, mother's position, that they can get into to help with that. And we're going to talk about that more when we talk about position changes in labor. So we'll talk a little bit about that as we go on. So the power, the uterus, as I've already talked about, is, you guys have found out that I like the uterus, is the other P, is the third P that we're going to talk about. So the power, that strong muscle that will contract and help to push the baby out. All right, and we've already seen this little video, so we're not going to watch that again. Psyche, as I can't push to you enough how important it is that you have a good psyche, that you have a relaxed psyche as much as you can. There's actually been studies that have been shown that you can actually slow your labor by being tense. The more relaxed you are, the less you're going to fight your body. When you are tense, you're fighting what your body's trying to do, and it can actually slow down your labor. If you are relaxed as much as possible, then it lets your body do what it needs to do and can help your labor progress. So our goal in labor is always to keep you as calm and relaxed as possible. So that's always our goal. And we know that that's going to help our patients have shorter labors, and everyone wants as short and painless of labor as possible. So those are things that we're going to try to work toward. So here's the opposite of a tense. Obviously, she's not relaxed. Her face is tense. She's probably grabbing onto something. I actually want you to have a relaxed face, relaxed shoulders, relaxed arms, everything just hanging as much as possible, so that your body, any energy is not being used in any other place of your body except for where it needs to be, and that is to get the baby out. So what is pre-labor? We're going to switch gears just a little bit, and then we'll go back to our labor topics. But what is pre-labor? So pre-labor is your body just getting ready. It's like the workout before the marathon. It can occur at any time between about a month before or right before labor onset. So it's not a for sure thing. And it doesn't mean that labor is going to start tomorrow. It just means that your body's getting ready. So some pre-labor warning signs are Braxton Hicks or warm-up contractions. So Braxton Hicks, they're not painful contractions. You can feel the tightening. You know that they're happening. That's not, a lot of times people are like, well, I've been having a contraction, but they don't hurt. So what we know with that is that labor contractions, Braxton Hicks contractions that aren't painful, they're probably not doing much. Okay, so they're not true labor contractions, but they are your uterus getting ready. It's learning how to contract, and it's learning how to coordinate its contractions. Lightning. So lightning is another term for when the baby drops. That's when the baby drops into the pelvis. So with lightning, or when the baby drops, a lot of times you might be able to eat more food because you have more space in your stomach because everything has dropped down. The other problem with that is that you might go to the bathroom even more than you already did because the bladder is being smashed even more. All right, so lightning. The mucus plug. There's a lot of talk about the mucus plug. And maybe support people are going, what? I don't know anything about the mucus plug, but mucus plug is actually located inside the cervix, and it is the first barrier to infection. The second barrier is the bag of water, right? So the first barrier to infection is the mucus plug. And as your cervix starts to do something, so as your cervix maybe starts to thin out or open up, to dilate, you might start to lose some of the mucus plug, or you might lose some mucus plug after your cervix is examined because it actually will loosen things up a little bit. Some people lose their mucus plug in one big, chunk. Some people lose their mucus plug just over a long period of time. One's not better than the other. It makes no difference. Again, it doesn't mean labor is going to start tomorrow. It doesn't mean labor is going to start, anytime soon. It just means that things are starting to happen. The one thing I always tell my people in my classes is that, it's great that it's happening. You don't need to go to the hospital. You don't need to call the doctor. You don't need to bring it in. All right. So the mucus plug is not an indicator of labor. It is just something to know that things might start happening. And it's literally what it sounds like. It is a mucus. It is very mucusy, very kind of gelatinous looking like discharge that can happen. And again, it's something that really just means that things are starting to happen. Nesting. So nesting is just, you may have heard of people that clean the house. They may, wash the baby clothes again. They just feel like this really intense need to get things done and to get things organized. So that's nesting. I never witnessed this, but I do know that it can happen, is a weight loss. So just a small weight loss at the end of pregnancy. So that might be that labor might be getting near. Again, lucky for you if this happens. Increased backache. So this is just, just kind of an early warning sign that, maybe the baby's lower, your back is hurting more. Back pain and back discomfort is so normal in pregnancy just because it pulls your body forward. Your back is actually curved in more than normal. So you're really off balance, and that's what causes that back pain. So just some things to kind of be aware of. All right, so the onset of labor. All right, so the onset of labor happens sometime between 39 and 42 weeks. All right, we don't really know what causes labor. We don't know why this happens. We think it's a cascade of hormones that probably starts with the baby. But again, we still haven't quite figured out the exact science of how to start labor. If your body's not ready to go into labor and we are trying to induce labor, sometimes we're unsuccessful. We really, we know a little bit, but there's still a lot that we don't know. So we're just gonna kind of watch this little video about this, okay?
When the time is right and your body has made its necessary preparations, you and your baby will start the exciting journey of labor. Typically, labor starts with contractions as the uterine muscle tightens and relaxes. Unlike Unlike warm-up contractions, true labor contractions don't fade away, no matter what you do. Instead, they develop a pattern. They become stronger, last longer, and happen more frequently. Once you begin having regular contractions, you should call your healthcare provider.
She's in labor for sure, and yeah, we want to wait a while longer at the house. And she wants...
The doctor or midwife will probably want to talk to you to assess how you're feeling.
Oh, I'm kind of having one, so it's hard for me to talk.
All right, so just a little bit about labor. So this is a slide that I really want you to pay attention to. This is kind of what is true labor versus warm-up labor or false labor. So there'll be some important information in this slide. So the main thing that I want you to get from this slide is that in labor, your labor contractions are going to get longer, stronger, and closer together. Okay, so in true contractions, they are getting closer together, they're getting longer, so the contractions are lasting longer, and getting stronger. Okay, so longer, stronger, and closer together. These are contractions that are progressive, all right? So they are getting worse. Each one is stronger than the one before. It doesn't matter what you do, nothing changes it. So they don't stop when you change your activity. So it doesn't matter if you're walking or if you're laying down, if you're doing anything. So it doesn't matter what you're doing. These contractions will continue. True labor, there's nothing you can do to stop them. Okay, so these are progressive. I want you to think progressive. Are my contractions being progressive? All right, so on the other hand, warm-up contractions, they don't have a pattern, okay? They might be every 5 minutes, every 5 minutes, every 5 minutes, and then they have you have a space that it's every 10. Okay, so they don't have a pattern to them. If you lay down and you're able to go to sleep, all right, if you're able to go to sleep, it's not true labor. Okay, so what would I say? Try to lay down and go to sleep. If you're able to go to sleep, it's not true labor. All right. The intensity doesn't change. They remain the same intensity over the time, okay? And so what happens is with these warm-up contractions is that they don't cause your cervix to change, and that is the main thing, is that they don't cause your cervix to change. True labor contractions causes your cervix to change. They are long enough, strong enough, and close enough together that they cause your cervix to thin out and dilate. Now, is that hard for you to know at home? Yeah, I know. That's hard for you to tell. But what you can tell at home is that you can tell that they are progressive, okay? So some things that I would say to do, if you're trying to figure out, is this labor, is this not labor at home? What are some things that I would maybe try to have you do? Well, the first thing I would say is, okay, and when you come in and we're trying to evaluate you for labor, that's one of the first things we're going to ask you is, how much water have you had to drink today? Okay, so we're trying to rule out, are you having these contractions because your uterus is dehydrated, or is it really labor? All right, so drink water. All right, eat something light. So make sure that you're not having contractions because you need food and water. And if you can lay down and take a nap, then it's not true labor. You will not sleep through true labor, okay? Fear not, you will not sleep through true labor. You will wake up if it is true labor, right? So just trying to remember that. And then think, are these contractions progressive? Are they getting longer, stronger, and closer together? All right. So speaking of how to time contractions, So this is how to time a contraction. Timing contractions is being able to tell how far apart contractions are. So you time contractions from the beginning of one to the beginning of the next. All right, so from the beginning to the beginning. So let's say that these dark lines are minutes. So this would be 1, 2, 3. So these contractions would be about every 3 minutes apart. Okay, and the other thing that we're going to want you to measure is duration. How long are the contractions lasting? So that would be simply from the beginning to the end of each contraction. So this would be about a minute long. So that is a nice length contraction. So we have these contractions are about every 3 minutes apart, okay, and they're lasting for about a minute long. All right, so what if your water breaks? All right, so if your water breaks, it can be a big gush or a slow trickle. But what I can tell you is that the bag of water breaking as the first sign, so you're not having contractions, your bag of water breaks just, boop, no warning sign, only in about 10% of women. Okay, so do know that. Again, it can be a big gush or a slow trickle. All right, so this is just kind of a little video of your water breaking. And so this is going to explain what a big gush would be. So if your water breaks low, below the baby's head, you're going to have a big gush of fluid, okay, like this. All right, but let's say your water breaks higher up here, and you might just get like a little bit of leaking of fluid as the baby moves. So that's where you might get a small trickle. So that is where it becomes a little bit more difficult to tell if your water breaks. So that small trickle can be where you might, where you might feel like, okay, I might be leaking. But then did I leak? Did I not leak? You know, did I have to go pee? You know, what is this? What's going on? So what I would tell you with that is I would tell you to put a pad on and see if it happens again. If it happens again, it probably is your water. And then we would want you to, you know, definitely have it checked out. So if it's your bag of water, it will continue to leak. All right, so it will continue to leak. It's not something that just happens once and never happens again. With your water breaking, some things that we kind of like for you to remember is down here on the bottom left is the little acronym COAT. So the different things that we're going to ask you about if we think that your water breaks or if you think that your water breaks. So what color was it? So let's say that you see it and I don't see it. You know, you come in and you tell me that you had a big gush of fluid, and so I'm going to ask you, what color was it? You know, so what color should your water be? It's water, and so we've named it that. So it should be clear, and that's normally what it looks like. Other colors that it can be green. And when it's green, it looks literally like, it actually can look like poop, because that's actually what it is, but it's actually from the baby. So it's when the babies had their first bowel movement in utero, so inside the bag of water, and now the bag of water, the water is mixed in with baby's poop. So that's what it will look like. So you'll kind of question yourself, where is it coming from? Is that actually, is that water? Is that my water? But it can actually be that color. And it is important for us to know that, just because we'll watch the baby more at delivery for any breathing problems after they're born. So, and you might see more of that if you have a big gush and then the baby's head gets well applied onto the cervix, and then I may not see as much until after the baby's born. So color, I would want to know color. Odor, so what should it smell like? Well, it's really kind of hard to explain, but I think it smells like amniotic fluid because of my 20 years of working as a labor and delivery nurse. But what it shouldn't smell like is it shouldn't have a strong foul odor. And that would be something that you don't have to tell us, we're going to smell it. And that would definitely be a sign of infection. So that would be something that we're worried about. amount. How much was it? You know, I've learned through the years that my amount description and your amount description may be two totally different things. So my amount description, you know, I want to know, you know, I have people that will say, I mean, I lost a lot of fluid, like it just came gushing out. And then when I ask them more questions about it, they might tell me, I'll ask them more specifics, like, so how much of it came gushing out? And they'll tell me maybe, you know, a quarter size on their panties. Well, that is not a lot to me. A lot to me is you're sitting on a beach towel and it's saturated. That is a lot to me. So how much was it? And that I kind of find with any description. I want to know an actual size amount that I can kind of, we can kind of correlate how much it is. And then time, when did it happen? Now, why do I care what time it happened? Does anybody think about that? Well, we care about what time it happened because what did I tell you earlier? That the mucus plug is the first barrier to infection, but the bag of water is your last barrier to infection. So we want to know what time it happened. It doesn't have to be an exact minute and second. So you don't have to tell me my water broke at, you know, 9:22. I don't need to know that specific, but I do want to know, you know, my water broke at 9:20, you know, even if it was, you know, within 5 or 10 minutes, that is fine. But we know that at around 18 hours, the chance of infection dramatically increases after your water's broke. So, you know, we do try to have the baby delivered by 24 hours after your water's broke. So that is why we want to know what time. So what I don't want to happen is I don't want for our patients to come in and say, I think my water broke, you know, last week or last Wednesday. That is something that we're going to be concerned about because we're concerned about the risk of infection for you and the baby. So that would be a reason why I need to know the time. Okay. All right, so stages of labor. All right, so let's talk about the stages of labor. So first stage of labor is when typically is what most people think about as labor. So this is when your cervix is thinning and opening up. So this is the typical labor stage. Second stage of labor is actually pushing and delivery. And then the third stage is actually delivery of the placenta. The placenta is a very important organ that everything that baby gets is through that placenta. So from I kind of talked about it earlier, but it is an organ that is made just for pregnancy, and everything that baby gets is through that placenta. So then the placenta is actually attached to inside the uterine wall, so inside the uterus, by thousands, if not millions, of tiny little blood vessels that are attached inside that uterine wall into that muscle. And then all the transfer happens through those tiny vessels. All right, so the placenta is very, very, very important. Without the placenta, you don't have baby. All right, and then fourth stage is recovery and breastfeeding. All right, so within those stages of labor, we have different parts. So early labor, so this is going to be in that first stage of labor. All right, so early labor, and early labor is still, you still don't know if you're in labor. This is early labor, and it's usually about 6 to 12 hours. All right, so does anyone know what the normal first time labor, how long a normal first time labor is? All right, so a normal first time labor is around 12 to 18 hours, and that's normal, okay? And a lot of people don't realize that, that is a normal labor time. They think, oh my gosh, that's so long. But when I talk to people that had, you know, an 8-hour first time labor, I mean, that's amazing. That's a very short first time labor. So even a 10-hour first time labor is very normal. So 12 plus hours is not abnormal. Active labor. So active labor is the time that you come to the hospital. This is the time that we are able to do things for you. Your labor is really progressing, your cervix is changing. So active labor is about every 3 to 5, lasts for about 3 to 5 hours long, okay? And transition. Transition is the worst and hardest part of labor. But luckily it's the shorter part of labor. So transition lasts about 30 minutes to 2 hours. Of course, all of these are, estimates, and every labor is different. So it's really, but this is just kind of what is an average times. So in early labor. So that early labor is when you really don't know. So early labor is very similar to what we would call like a false labor. It's really hard for us to tell until it progresses, whether it was early labor or whether it was false labor. So in early labor, your contractions still are pretty irregular, 5 to about every 30 minutes apart. They really don't have much of a pattern yet. They are pretty short in length. So they they're, like I said, they're pretty short in length. They maybe only are lasting maybe 30 to 45 seconds. Nice and short. They're still, you might have every 5, like I talked about earlier, every 5, and then have a 10-minute break. You're still pretty comfortable. And so you're still pretty happy in early labor. So here's just kind of a little video that kind of talks about early labor.
This animation shows the changing cervix. During early labor, the cervix dilates from 0 to 6 centimeters and begins to thin. In order for this to happen, contractions must gradually become longer, stronger, and closer together. Marimar's contractions are not very strong yet, and she and her husband Tim try using movement to get labor going.
During early labor, I was trying to relax. I tried a couple of the techniques that they showed us with the birthing ball, which were very helpful actually, because I was experiencing some back pain too, which I hadn't experienced up until that point.
I was trying to keep mentally present enough to be able to help. I was just enjoying the calm parts before we actually got to the hospital.
Your emotions will change throughout labor. During early labor, you might feel excited because your labor is underway. It's also perfectly normal to feel a little anxious about how your labor will progress. During early labor, Jenny decided to stay at home and distract herself with a game and rest when she could. She also nourished herself with light snacks and drank plenty of fluids.
Well, I started to feel some small contractions, and so then we decided that we wanted to have some distractions, some games, and have some fruit, and he was constantly trying to help me with making sure I had enough water, and so that was helpful.
All right, so early labor. So again, they're just trying to figure out, am I in labor, am I not? Some things that I would say is to rest, eat small, frequent meals, and stay hydrated, and just kind of see what happens. It's either going to progress into active labor, or it's going to stop, and then it could be a trial run. So. And it's really hard for people to not know about that. But that is why we don't have you come to the hospital in early labor, because again, it's really hard for us to tell also until it does progress, whether it is active or whether it is true labor or it is just a trial run. All right, so speaking of active labor, when do I go to the hospital? All right, and this is usually an issue, people want to know this. So what we have it spaced out is a 5-1-1. So when your contractions are about every 5 minutes apart, they're lasting about a minute long, and they've been that way for about an hour, okay? So that is when we want you to come to the hospital. If you live farther away, you might want to talk to your doctor about when they want you to come to the hospital. Other reasons to come to the hospital is that if you're vomiting with contractions, if your contractions are so strong that they're making you vomit, then you would need to come to the hospital. So you feel rectal pressure. So this is not the normal pelvic pressure that you've been feeling. This is, I'm going to have a bowel movement, rectal pressure, okay? That would be obviously a reason. You're unable to walk or talk through contractions. So you just really cannot stand the contractions pain anymore. And that would be a reason. You think your water broke. All right, so again, we want you to come in and have that checked out. That is something that it's really hard to tell over the phone. But so if you think your water broke, you have any vaginal bleeding. So this is going to be vaginal bleeding that looks like a period. All right, that is a reason to come to the hospital or to call your doctor. You might have some what we call bloody show during labor, and what that is that you might have some mucousy discharge that has some bloody streaks in it, and that's okay, but nothing like period bleeding. That would not be normal. Again, if you live far from the hospital, you want to talk to your doctor about when they want you to head to the hospital. It's going to have to do with, is it your first baby? Is it, your second or third baby? That's going to make a difference. What was your cervix when it was checked before? Those kind of things. So, or if you do have a history of progressing quickly. So that would be another reason to come to the hospital. All right. Make sure your doctor and you are on the same page about when they want you to go to the hospital or when they want you to call them. All right, active labor. So active labor is when we actually have you come to the hospital. These are when your contractions are about every 3 to 5 minutes apart. They're about a minute long, and they've been that way for about an hour. We have you come into the hospital. So this would be active labor. All right, usually you can tell when a mom's in active labor, she's serious. She's not all about bonding and making new friends. She is focused on the task at hand. Her contractions are definitely getting stronger and longer and closer together. This is when typically the cervix starts to change about 1 centimeter an hour. So that's when we can really tell that labor is progressing. And this is when we can start introducing things to help her. So pain management, so things like IV pain medicine, epidural, those kind of things.
At this point, these stronger contractions are working to thin and open the cervix from 6 to 8 centimeters. Laura and Brandon have been laboring at home all day and are now trying to decide when it's time to go to the hospital.
I don't know what we should do. So I just don't know how long we should stay here.
Another one's coming.
No one's coming.
Oh, don't take the pressure off. Ooh. 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 I think we need to get ready to go.
Okay.
As the intensity of active labor increases, your emotions will likely change, becoming more serious and focused. This is the time to tap into your inner strength and rely more heavily on your support people.
We're going to the car.
It's time for Janine and Brandon to go to the hospital. Her contractions are very strong now, making it difficult to get to the car.
Come on.
Okay.
You want to stop here?
So with me being the sole support person for Janine when she went into active labor, I felt a lot of responsibility to make sure things went well, to make sure things kept on moving forward. Yeah, just to be that solid rock.
Oh, goodness. I mean, at that point, I was making all kinds of noise. It was just really hard to get through those contractions.
It's such a strange feeling to see like how you focus for contractions, because in the moment you really block everything out. I blocked everything out. I don't know what was going on around me. Nothing else really mattered, but I just got in the zone, and just kind of these like primordial instincts came in, and I just basically blocked everything out.
She went from dealing with the pain pretty well to having to breathe through it, using me and her father to get her through it, because they slowly got harder and harder and harder.
All right, so you can tell in that video how serious the women are about active labor, and how that you really have to become focused, and you kind of start to focus on the task at hand. All right, so active labor. So transition is the next stage. Transition is luckily the shortest stage, but it is also the hardest stage. So in transition, we have longer contractions. So contractions that are about every 60 to 90, or that last about 60 to 90 seconds, and they're about every 1 to 3 minutes apart. So your rest period is not very long. It is, like I said, it is a hard part of labor, but it is getting a lot of work done. So again, longer contractions, and they're happening more often. So you really only have like maybe a minute of break. It is getting through the last part of labor. So you're getting your cervix is dilating to 10 centimeters, getting rid of the rest of that cervix. This is when people get very frustrated, emotional. They might not think that they can do it. They might not think that they can handle it. They may say, I'm giving up, I can't do this anymore. A lot of times I have patients that are, that's kind of what they say. So if we can get them through this part, then, you know, they just need a lot of hands-on support. They don't, a lot of times women in transition don't realize what is happening and how close they are actually to delivery.
Active labor progresses into the third and final part of the first stage, called transition. During this part, your cervix thins and opens completely from 8 to 10 centimeters. Because of how intense transition is, you might feel overwhelmed and more dependent on others.
I'm gonna throw up.
Miramar experiences nausea and vomiting as she progresses to transition.
I am going to try to restart this video. It's not showing us what we need. Let's try playing this again.
Active labor progresses into the third and final part of the first stage, called transition. During this part, your cervix thins and opens completely from 8 to 10 centimeters. Because of how intense transition is, you might feel overwhelmed and more dependent on others.
I'm gonna throw up.
Miramar experiences nausea and vomiting as she progresses to transition. It's also common to experience hot flashes, chills, or shaking.
My water broke right before I was fully dilated.
The water broke.
And so that was part of transition. So looking back, I can kind of decipher like what the stages were, even though it was such a blur, but I knew that that was transition.
Contractions are usually at their strongest during transition. Continuing to use a variety of positions and comfort techniques can help. Chrislyn, a third-time mom, is now going through transition, and her labor has progressed quickly. Her husband Marcus and her other support people work to keep her focused.
We just need to shift our attention to, getting her to realize that, she could do it, that it wasn't an impossible task, and that she was a strong enough person, and it's been amazing to watch.
All right, so transition. Obviously, that's when things get very real. Lots of hands-on support happens in transition. You want to make sure that you're giving her very encouraging words and those kind of things. Second stage of labor. So this is, we went through the first stage, which is dilation. And the second stage is pushing and delivery. So now we're going to, our cervix is completely dilated, and this is going to be pushing and delivery. So with pushing and delivery, a lot of times what happens is that we have a rest period. Unluckily, our contractions might actually not lighten up, but actually might space out to give us time. So sometimes you get they might space out so that we have some time to recover in between those contractions with pushing. All right, a lot of times at this time, women get relieved. You are definitely exhausted at this point, but it really is the light at the end of the tunnel, and you really are almost done.
Laura has a short resting period after she's fully dilated, then feels a strong urge to push.
Can I push? Can you get
I did not know how to push. I just kind of put my head down like they said. You kind of want to put your head down and push down with it. And I basically just pushed from like the bottom part of my body. And I don't think I knew what I was doing, but I felt the pressure of her coming. So I just kept pushing with that pressure.
At this point in labor, the top of the uterus is very thick and pushes on the baby with each contraction, helping the baby to move through the pelvis. Pushing in an upright position helps this process along and uses gravity to its advantage. You might feel an overwhelming mix of emotions during this stage, such as relief and a burst of energy. You may also feel exhausted and frustrated, especially if pushing takes longer or is more difficult than you expected. As you push, your baby's head will move down and then slip back slightly between contractions. To help your baby's head descend more easily, her skull is made up of separate bony plates. These plates slide together to help her head fit through the birth canal, giving many newborns a cone-shaped head after birth. Don't worry, this will only last a few days.
All right, so just kind of talks a little bit about that second stage in pushing. So some different pushing positions that we're going to talk about. Some different pushing positions. So let's talk about hands and knees. So hands and knees is a great position to push in. Actually can help rotate the baby. Another pushing position is squatting. Squatting actually helps open the diameter of the pelvis. It actually has the widest diameter of the pelvis is in the squatting position. Laying on your side and pulling your leg back. That also helps to rotate that baby's head. So us changing positions is going to help that baby work its way through that pelvis. Changing positions in labor is very important. It helps that baby get into an optimal position. So definitely position changes are very, very important. Also on a birth stool, we do not have birth stools, but actually pushing in a squatting position is very similar to that. Sometimes if you're far from delivery, sometimes and you don't have an epidural, sometimes you can push setting up more in a setting up position that is feels a little bit more natural when you're pushing. All right, different positions in labor are also very important. So I always tell people that we want you to change positions at least once an hour, if not more. All right, so while laboring. So, you know, and I also want you to get up and empty your bladder at least once an hour. So that counts as a position change. That's you getting up, going to the bathroom, sitting on the toilet, walking back to the bed. Those are all going to help that baby come down into the pelvis and get seated into the pelvis in the best way that they can. So those are all things that is going to help you.
When it's time to push, you can try positions that use gravity to your advantage. Instead of lying flat on your back, try squatting, semi-sitting, side lying, hands and knees, and sitting on the toilet early in the pushing stage, or sitting on a birthing stool if available. You might use several of these positions over the course of the pushing stage, and you might push in one position and then give birth in another. Keep in mind that certain positions aren't possible if you have an epidural. Certain pushing positions also put less pressure on your perineum, which might reduce tearing. There are many ways to push. Some women wait for a contraction to build, then push for 6 to 8 seconds, taking a deep breath between pushes. Other women push for shorter periods, but more often during a single contraction. Your care provider will help you figure out which technique works best when the time comes.
I had mentally prepared myself for that, about how important it was to, once you get them down there and see them down there, how if you can be patient, that it helps prevent tears. I was watching it in the mirror too, so I could see what was happening, and the midwife would say, okay, just little pushes. And I sort of held her there for a little bit. I really didn't want to see her go all the way back up again.
All right. So with pushing, we want you to try to get around 3 to 4 pushes with each contraction. So kind of how they talked about, some women will take multiple deep breaths in between. Some people will take one big deep breath in between each push. It just kind of depends on what you feel like you need. So what we want you to do is we want you to push and bear down as long as you can. So hopefully it's around 6 to 8 seconds, and then take a breath and bear down again. It's really difficult to bear down effectively while breathing out. So what we usually will have you do is bear down and push all the way through the center of your body. And you're pushing just like you're having a bowel movement. It feels exactly the same. It puts pressure on exactly the same nerves. And so you actually want to push just like that. And sometimes, it's a learning technique. So we have to kind of talk through pushing. If you don't have an epidural, you're going to instinctively, your body pushes with or without you. But with an epidural, sometimes it does take some learning and some practice. So it might take us a while to kind of get the hang of pushing effectively. All right, so third stage is where the placenta delivers. So the placenta, again, it has its own stage, and that happens anywhere between 5 and 20 minutes after birth. It's not painful, but you might feel one more big contraction, cramp. It is soft and squishy, so it's not going to be anything like the delivery of the baby. All right, and so this is just going to show the release of the placenta and what happens to the placenta and the uterus. So I want you to kind of take look at how the uterus, once the placenta actually delivers, then the uterus, once everything is out of the uterus starts contracting down and getting smaller immediately. And that's actually what helps control the bleeding, is the contracting. So the contractions or the squeezing helps to actually put pressure on all those open wounds that are inside the uterus, because I told you it was attached by, millions of tiny little blood vessels on the inside of the uterine wall. And so that uterus contracting down, squeezing, think about it as applying pressure to the bleeding wound, helps control the bleeding. All right, so that is what is happening to your uterus after delivery. It's a pretty amazing organ, and it actually shrinks down to that, from the size of holding that baby and holding all of the pregnancy. It actually shrinks down to below your, right at your belly button, and it feels like the size of like a softball. It shrinks down that fast and that small, and it should feel like a nice, firm, hard softball. And so your nurse and your doctor will feel, we will feel about your belly button and feel, is that what the uterus feels like? So it continues to shrink down. Holding your baby skin to skin helps your body produce oxytocin and helps control the bleeding with that. In the hospital, we actually give you IV Pitocin. Even if you don't get it for your labor, you get it afterwards. And that's to help control bleeding and to help your uterus contract down. It's not going to cause you the pain like it causes during maybe if we're using it to cause contractions, okay? All right, so here we go. Here is our first birth video. Let's watch this from start to finish.
The baby's head crowns when the vaginal opening is stretched to the fullest and her head does not slip back between contractions. You might feel some burning and stretching during crowning. Next, your baby extends her head and lifts her chin, allowing the crown through and out the birth canal. Her head starts emerging face down and then turns to line up with her shoulders, which are still inside of you. With the next push, one shoulder comes out and then the other. The rest of your baby slips out and she is born.
She was born, like feeling your head come out and then like just feeling the body come out. It was such an intense emotion. It really was just such a piece of heaven for me.
Good job, that was perfect.
Finally seeing what was inside of Laura was incredible, and she's ours and our responsibility and something that we get to raise forever, so it's great.
Stop pushing. Okay. Breathe. Hi. Hey, here we go. Look down. Hi. Here she comes. Here we go. Nice work. There. Look at her. Little bracelet. Hi. I'm gonna put her up here.
If there are no birth complications, your doctor or midwife will hand you your baby right away. Holding your baby skin to skin on your chest after birth, with no clothing or blankets between you, helps stabilize her temperature, breathing, and blood sugar levels. You may notice that she calms down when she feels your warm skin.
Look at that head full of hair.
All right. So there was our first birth video from start to finish. Of course, all of these that I'm showing you initially, they're all unmedicated deliveries. And there's a reason for that. I want to show you an unmedicated delivery first, and then we'll talk about intervention. So that is coming. I do want you guys to all pay attention to the unmedicated deliveries, because sometimes even our best plans, we may not have the pain control that we want, or we may not be able to get the pain control for one reason or the other. All right, so just kind of a reminder about that. Just kind of a little joke here that everything's going cordless. Ha ha ha. those are just kind of nice reminders about why we're here, and that it's to bring a life into the world. So when you are watching that video, and as you watch the next video, I want you to think about what you see. Is there anything that surprises you? Is there anything that you would maybe want to use in your own delivery experience? Is this something, is it different than what you thought it would look like, and maybe how people cope? Those kind of things. So some different things to kind of think about as you're watching the video.
How do you fold those? They're so small.
Hi, I'm Brandy. I'm 37 weeks.
I'm Shane, Brandy's husband. Oh, I can't wait. And I can't wait for her to feel better again.
I'm like, I'm ready to be done with this, and have my little baby. Having an unmedicated birth is really important to me. Women have been having unmedicated births for thousands of years. It's a primal instinct to bear down, to get in the squatting position, to breathe through it, and, just allow the body to do what it needs to do. So I'm excited for that. Contractions started actually the weekend before that he was due, which was really exciting. So my labor support team included Shane, my mother, and then my doula, Molly. I can feel more on this side. Early labor contractions that definitely felt stronger than Braxton Hicks. Some at one point I could feel kind of start up at the top and kind of push down. It's just the weirdest experience. This is really the uterus actually doing its thing. Like right there. As we were timing them, it was like, oh, okay, they're pretty regular, because before they weren't regular. So we're like, okay, this is it. My doula, she had come with a bunch of oils and stuff, so she was doing massaging, and that was nice.
During the early labor, to help Brandy with the contractions, I was just trying to, suggest things that may help. Rubbing her back a lot, massaging her legs, her feet, just trying to keep her comfortable.
Then we did do some yoga moves and, kind of doing some stretching, and so that did help. Other times it was like, okay, I just feel like dancing, just kind of sway. So I'd lean up against Shane.
I made the call to the midwife just to kind of get some clarity.
Westside Women's Care Answering Service, how may I help you?
Hi, I'm just calling to give an update on my wife's status with her labor.
Are you having one?
Yeah, hold on a second.
I'm having one. Okay, so, well, yeah, I guess we'll just kind of keep counting and see how far apart they are.
She basically said just, kind of wait, but did, tell me if I felt like I needed to go in, then just go ahead and go in at any time that I felt like it. So we waited.
Oh, yeah.
After the whole night of laboring and stuff, we decided, okay, let's go in. We started walking around the hospital, and it's like everything started feeling funny.
Definitely mild contractions, everything's hard.
There's so many emotions. It was, fear and excitement, and there's so much going on. It was hard to describe.
And I realized this is different, than from the early home labor stuff. So that's when after a bit, I was just like, I need to get back to the room and just be there. That was kind of like my comfort zone. Like, I don't want to be out walking around. I want to be in my room ready for whatever happens.
How's that pressure at your hips? So we're just opening the pelvis, okay? So pull your... There you go. That's good. Does that feel okay?
Once I got into the tub, I was kind of like, okay, this is nice. I'm just kind of chilling, relaxing.
I got in the tub with Brandy just so I could be there with her.
You having another one? No.
She could lean on me. Sometimes those tubs aren't very comfortable, so it just gave her a little support.
It's okay. Are you feeling overwhelmed? Nice and slow. Slow it down. There you go. All the way in. All the way in.
Do the diffuser? Yeah, it's just the same amount. Okay.
And I remember a few times Molly, you know, kind of talking, doing a visualization.
Right away, right? So slowly on.
You know, each contraction was just a wave, and she was like, just ride with it, let the water flow over you. I'm like, okay, I can do this. I'm just sitting there, I'm rocking with the waves, just rocking with the waves.
So from what I can tell, 5 to 5.5, okay? Baby's head is really low. That's why you're feeling pushy, but we're not at the pushing place yet. So this is a good place to have you here in the tub.
When they told her she was at a 5.5, I was excited because I've always heard that from a 5 on, it really progresses and gets there pretty quick. So I knew that she was dilating more.
After a while, I was just like, I couldn't be in the tub anymore. Somebody had mentioned, let's get into the bed. So I was leaning up against the back of it and kind of, you know, rocking there, up and down, and kind of side to side. We had got the peanut involved. And then I was like, well, I don't like that. Let me see if I could drop down to the next level, and kind of moved around there.
And then you can just lean forward.
After a while, I was just so tired that I was like, I just need to lay down for a bit and rest. As each contraction came on, somebody had my leg and they were pulling it up towards me and just kind of rocking it back and forth.
It was interesting that she came up with that on her own and just like, okay, you know, do this. And, you know, she took control and made sure everyone around her was doing what they needed to do.
So in between contractions, it was just like that relief. It was like, oh my goodness. Big sigh of relief. It's just like, I can relax now.
That's a good job.
You know, I knew Brandy was getting close. I think she was about 7 centimeters, 7.5, somewhere in there. I wasn't much help if I was completely exhausted, so I figured I'd just take a nap and build some energy.
You just tell me if it's too much or if you want me to stop, okay?
I felt the contraction coming on, and Molly was behind me, you know, and that I still had to keep that kind of squatting up and down movement. And then all of a sudden I felt her legs come in between mine to help support. So she was just literally holding on to me and helping me up and down because she could tell that I was starting to get tired and was just moving me through the movements. And I felt like an icky feeling. And so when it got to that point, I was like, I have to get back in the tub just to kind of cool myself back down and just kind of get back into like a nice, relaxed state. I'm not even sure if I knew I was in transition. It did feel different then, just because it's like I could tell just like the wear on my body. felt like a death grip on like the faucet and the bar and stuff. And then I remember the midwife like, let's check you again.
So I'm gonna check you. Let's see if we can do this.
There you go. Just gently slide.
She's just the anterior rim. So she's 9.5.
And it was like, a half? Why? It should be 10. What is up with this half stuff? Nobody ever mentioned anything about halves.
I just knew it was go time. I was ready for it. There again, it was the whole rush of emotions, like when we first realized it was time.
And then midwife checked one more time. She was like, all right, you ready? And I'm like, heck yeah.
Perfect. Now she's complete.
Keep it going, Brandy. One more.
You know, I rather wanted to do it in a squatting position, but I've been squatting and doing lunges and squats and everything else for hours and hours that once I was on that bed, I couldn't move.
Down your spine, out your bottom.
And I was like, everything's opening. This is it. We're so close.
When I first saw Hunter's head start to come out, I could see his blonde hair, and it just, it was like, oh my goodness, it's a real human being, and he's gonna be here soon, and I couldn't wait to see him.
He's right there. Do you want to feel his head?
Oh yeah, you can definitely feel his head.
See, there it is. Feel his hair. That's his hair. Yay! One more big push. Out the bottom, not the face. Right there.
You got it.
You got it. Breathe in. Everything out. Everything out. Everything out. Good job. Good job. Now please go. That's your baby. Say hello. World, little man. Lift him up. There he is. Awesome.
Oh, he's not 9 pounds.
Okay. There he is. Say hi, Mama. Yeah, there. Good. He's trying to breathe.
That whole like, I don't have to do anything now. I'm done. I'm done pushing. Like whatever energy I have to just be here.
Welcome.
I remember Molly, she's like, you want to start breastfeeding him? I'm like, okay, how do I do that, you know? Oh, it was like so surreal. I was like, wow, it's like I have my baby in my arms and he's eating right now. So, I mean, it was exciting.
Being such a big role in Hunter's birth was pretty amazing. It gave me a new view on life. Brandy's amazing. Like, she is absolutely my hero. Just seeing her go through that and just be so calm, and super proud of her. And it's pretty amazing to have a newborn in the house that I can't keep my eyes off them. Just always want to hang out with them, check them out.
It's just wonderful waking up and like just looking at him and just like, wow, you know, I created that, you know, I birthed that.
All right, so here's those questions again. Is there anything that surprised you during that delivery? I think some things that probably would surprise people is the length. You know, she had a long labor, but she made it through it. And is there anything that maybe you would want to use? Some different techniques, some different ways of laboring. So just something to kind of to think about. All right, so just kind of remember, be patient and let nature take its course. All right, so next we're going to talk about what we can do to help you to deal with that pain. So first I'm going to talk about relaxation techniques and comfort techniques. So these are going to be all non-medicated ways to deal with pain. all of these techniques are going to help you, and you can use these anytime in your life to deal with pain. So I kind of mentioned earlier that I know there's people that, you know, I want my epidural tomorrow just to make sure that I get it for labor. I understand that, but some things happen, and sometimes there's reasons why you don't get that epidural, or maybe that epidural doesn't work as good as that maybe you wanted it to. So these are things that can help you along with that epidural. Or I also know that there's people out there that, you know, they don't want an epidural, or they don't want any pain medicine. And so these are things that can help you deal with labor. All right, so let's just talk about a few of those. Who's going to be there with you? You want somebody there with you that is a good support, somebody that knows you. You guys need to be honest and open about what you want, and agree on what is going to happen in labor. You know, agree on the pain medication yes or no questions. So those are things to talk about. Things to pack. This is a question that a lot of people have. So this would be what to pack to help you through your labor process, okay? Not just definitely for the hospital stay, but to help you through your labor process. So these are some different things to help you through that. Having something, some kind of aromatherapy. So that can be simple, some kind of a room spray. That can be the wax melts that you can have, you know, the kind that you just can buy at the store. You can have essential oil diffusers. Those are all different. You can have a plug-in. Those are all different things. Just something that, whatever scent that is soothing to you. Now, make sure that we can turn it off, because you may decide, I don't want to smell anything, and it may bother you as labor progresses. Everyone's different, so just kind of as labor goes along. Some kind of music. A lot of times people just use the music off of their phones. Some people just turn on their phones. Some people bring little speakers. Either one is fine. Some people wear headphones, and that works well too, just to kind of keep her focused. What kind of music that you use, it doesn't matter to me, but typically it needs to be have a slow rhythmic count to it. Nothing too fast, nothing too crazy. But I have had people that that's, you know, they labor to, you know, hard rock, and that worked for them. So snacks. So these are not going to be snacks for mom. These are going to be snacks for the support person. So we want something that is has some protein in it, that is not just sugary snacks, something that has substance. You know, in the middle of the night, there's not as much opportunity for to go get a snack. We do have over in the regular hospital, there are some vending machines with some snacks in it. And we do have some things on the unit, but if you needed that. Your baby book, that is something, you know, just to have. As far as baby books, we will do their prints and do those kind of things, but we usually wait until after their bath. So we just do that sometime before you go home. If you actually are using a camera and you're wanting to kind of use a good camera for delivery photos, make sure that you know how to work the camera, make sure the battery's charged, all of those things. So that at delivery, we do allow you to take pictures. We just don't want you taking any pictures of any procedures, the baby actually coming out of your body, those kind of things. And then be aware of taking pictures of staff members, so that you're not able to identify staff members in your pictures. Massage aids, so that can be lotions, smell good lotions. There's all different massage aids out there, you know, things like little handheld ball rollers, those kind of things. Those are always nice to have. Comfortable clothes. I always tell you to have something to put on your feet, whether it's slippers or flip-flops or something. You just want something on your feet before you're walking on our floors. And then, you know, some kind of comfortable clothing. You can wear, if you want to bring your own gown to wear in labor, that's fine. Just know whatever you wear, make it messy. You can wear a sports bra, that's fine. We just don't want you to wear anything with wire in it. So, but a sports bra is okay. You can also wear like a cami, those kind of things, if that makes you more comfortable than wearing our gown. Or you can wear that under our gown too. That's also an option. All right, so based a lot of our relaxation techniques are based off of the fear, tension, pain cycle. So basically what this is it's a vicious cycle. One causes the other, and then it just kind of repeats and repeats and repeats. So if you have pain, you get scared and then you tense up, and then you have more pain and then you get more scared and then you tense up even more, and it's a vicious cycle. So we have to figure out what we can do to help stop this cycle. There's many different things that can help stop this cycle, but is it, educating you so that you're not as scared? Okay, so that might be part of it. And then figuring out what we can do to not cause you to be tense. So whatever causes you not to be tense. So that's really what we're trying to do. Again, I kind of mentioned earlier that the more tense you are, that you can actually slow your labor. And they've done studies on that. So, that is a proven thing. So the more relaxed we can get you, the better. So think about things that make you relaxed, that works for you. So this is it's different for all people. So is it gonna be, certain smells make you relaxed, make you feel good? Is it gonna be music? Is it gonna be decreased lighting? Is it gonna be all of those things? Sometimes it's many things, but we have to figure out what works for you. So this is the gate control theory. So what I want each of you to do, and of course, now that I'm not doing this in person for you, I can't make you do it, but please do it. I want you to each put each hand on each forearm. So one hand, your right hand on your left forearm, and your left hand on your right forearm. All right, so that your arms are crossed. And then I want you to pinch your arm. Okay, so pinching your arm so that you have discomfort. You know it's happening. Okay, so pinch your arm with one hand. And then with the other hand, I want you to just stroke that other arm. Just rub that other arm. Now, while you're pinching, you know you're pinching still, but the pinch feels less while you're stroking your other arm. And that's simple gate control theory. Just that simple touch of you touching your arm helps you release endorphins. And endorphins are your feel-good hormones. So endorphins actually reach the brain, or your feel-good hormones actually reach the brain before pain. So pleasure gets to the brain faster than pain and actually helps to block some of that. Now, I'm not here to tell you that if I massage you, you're not going to feel any pain, okay? But what I can tell you is that whatever I do to help you produce those endorphins, help you produce those feel-good hormones, is going to help you and have you perceive less pain. All right, so this is going to work even in addition to pain medicine. Okay, so whatever we can do to help you produce those feel-good hormones is what I need to do. Okay, so we want you to produce the feel-good hormones. That is a good thing. So some different ways to help you produce those feel-good hormones is your labor environment, what you can do with that. So having decreased lighting, decreased stimulation. Sometimes just having that music playing, you may not even be listening to that music, but it might cover up other sounds, like maybe alarms monitoring what's going on out in the hallway. Do I hear the person next door? We don't need you to be worried about those kind of things. We need you to be worried about the task at hand. So sometimes it's just simply to help drown out those other sounds. Is it too hot or too cold in there? You know, what do we need to do to adjust it? Do we need to get a fan for you? Those kind of things. Smells. A familiar smell helps to relax you. We all know that lavender helps to relax. So something that smells like lavender. Familiar things from home. I usually say bring your own pillow from home. Our pillows are not good, but the pillow from home also has that pillowcase on it, and it smells like home. So that is going to be comforting to you. It's going to help you feel safe. All right. And again, whatever I can do to help you produce those endorphins are going to be what helps you to relax. Visualization. Okay, so before we even talk about it, let's just kind of do this little learning. All right, so I just want you to kind of watch this. All right. Okay, so each of those were 30 seconds. One was obviously much more painful to watch than the other. And hopefully it was the one that of the clock that was much harder to watch. So the one with the wave makes time pass much faster, and it's much more pleasing and relaxing. So that is visualization. So what you want to do is you want to, sometimes people visualize, like in Brandy's situation, they had, she's like, ride the wave, ride the wave. So that was her visualization. Sometimes I've heard people visualizing colors. They tell me they visualized a certain color that was very soothing to them. A lot of people close their eyes while they're in labor. So, maybe when you're having the contraction, you imagine yourself, getting to the top of the hill and just going over a hill and going over the peak of the hill. That is visualization. It can be that simple that you're actually visualizing yourself making it through or helping yourself to relax. All right, so visualization is something that maybe you can practice. There's all kinds of visualization apps out there in meditation that you can work on. So maybe one of those might be something that you listen to, or that your support person just kind of talks you through it to help you get through each of those contractions. Massage. So massage, just a simple touch helps you produce endorphins, even though you just touching yourself helped you produce endorphins, which is crazy, I think. But definitely the touch of somebody else helps you produce endorphins. Massage, typically in labor, they want a firm pressure, nothing light or fast. So typically it's a firm pressure that is slow and rhythmic, okay? Some women don't want to be touched. Everyone is different in labor. So it just kind of depends. And you may like massage early on, or you didn't like it early on and then you want it again. So all of these techniques, sometimes we have to bring them back out or try them again. Just because we didn't like them earlier doesn't mean that they may not work for us this time, or we may like them better the next time they're tried. And just kind of remembering that gate control theory. Okay, so whatever I can do to help you produce those endorphins. And a lot of times it's many, many things that are helping you produce those endorphins. So breathing. Breathing is something that we hear a lot about in labor. I want to learn breathing techniques, or I want to, am I breathing right in labor? There's really no wrong or right way to breathe in labor, but you really just want to make sure you're taking slow, deep breaths. So breathing in and out. You don't necessarily have to breathe in through your nose and out through your mouth. Some people, a lot of women at the end of pregnancy have very swollen nasal passageways, and that's just from your hormones, and that's normal. You feel really stuffy, so breathing through your nose, sometimes you feel like you're gonna suffocate. So that it's okay if you aren't breathing in through your nose and out through your mouth, but just taking slow, deep breaths during those contractions is what I find actually works the best and works the longest for. Sometimes when that stops working, then we might have to move on to another breathing technique that helps us. But the slow, deep breaths. And so how we work that slow, deep breaths is that you actually are taking a deep breath in and you're blowing out to the count of 4 or 5. So on your exhale, you're thinking 1, 2, 3, 4, 5. And then another deep breath in and blow out to the count of 5. 1, 2, 3, 4, 5. Okay? Because many times what will happen is that you'll end up breathing way too fast, much faster than you even think that you are breathing. And so support people, that is a big part of your job, is to help her with that, is to help her get through that and not let her breathe as fast as she's maybe wanting to breathe. Because actually the slower you breathe and the more relaxed you are, that will help labor progress. So we don't want anything fast. We don't want anything tense. Okay. All right. Let me go through. I'm going to show you this video on breathing here.
Another effective technique is the use of breathing to reduce discomfort. Breathing helps in many ways. It makes your contractions work better as it brings oxygen to your uterus. It aids your baby's descent because it relaxes your muscles, and it provides a distraction. You can use slow, deep breathing throughout your contractions. Imagine that each inhale brings strength, while each exhale pushes out pain. Or you might find that faster-paced breathing helps with stronger contractions, especially during their peaks. Introducing a pattern or rhythm to your breathing can be helpful and adds a greater distraction.
Breathe in, breathe out. Good job.
There's no right way to breathe during labor. If a certain technique or pattern is helping, then it's right for you.
I basically just breathed and got in my little hurdle position and just breathed it out. And then I could feel the contraction slowly come down, so my breathing would become slower, and then it'd be over. And then you actually feel completely normal when you're not in a contraction. So it's a very strange roller coaster that you go through.
All right, so again, just kind of, I do want to talk a little bit more about that they kind of talked about. You know, having those deep, slow, deep breaths also help, you know, oxygenate your uterus so that it will contract effectively, and also gives that baby everything that it needs for that contraction. So during your contraction, after a contraction reaches a certain intensity, there's actually no perfusion in between the baby and the there's no perfusion in between the baby and the uterus. So through that placenta. So the baby has to have reserves to make it through that contraction. So you holding your breath is going to actually decrease that blood flow even more. So we need you to take those slow, deep breaths for your baby's sake and for you. So taking those slow, deep breaths are going to help you deal with that. Your baby, during those contractions, what helps you with that is going to take a cleansing breath. So you want to take a cleansing breath before and after each contraction. So taking a cleansing breath before the contraction, so as the contraction begins. So you just take a big deep breath in and blow it out. And that is going to tell everyone that's in the room that, hey, I'm getting ready for contraction, and kind of help me focus on that. And then at the end of the contraction, taking one more big deep breath, take a big deep breath in and blow it out, is going to help you get rid of that contraction. You don't want to hold on to any intensity of that contraction. You just want to let it go. And you want to relax your entire body in between that contraction, because as I kind of mentioned earlier, is that's the only break that you're going to get. And you want to utilize that break to the fullest so that you are recuperating and getting ready for the next contraction. So you want to take that big deep breath in, blow it all away, relax everything, relax from your head down to your feet, and let everything hang so that you're not holding on to anything. All right, and a lot of times during those slow deep breaths, during that contraction, what I will have patients do is do a progressive relaxation. And all of that is reminding yourself when you're breathing out is to relax your face, relax your shoulders, relax your arms, relax your legs, and letting it all hang. Take a deep breath in again and reminding yourself again. So support people, that's something else that I will have you watch for, is that make sure that her shoulders are not touching her ears, that she's not so tense that she's got her shoulders completely, and she's grabbing onto the rail and she's doing that. That is not going to help her. So we want to try to help her and remind her to relax and to let those shoulders hang and her face hang. That's going to help her labor progress. All right, hydrotherapy, so water therapy. We actually do not have tubs at Liberty Hospital, but I do tell people, if you're trying to figure out if you're in labor or not, you know, take a bath, take a shower, and see what the contractions do with that. We do have showers, and we have a multi-jet showers at Liberty Hospital. And we do have the handheld showers and chairs that you can sit in. So in order to be able to use those, you're going to need to be unmedicated. So we can't have you on anything that's causing your labor or receiving any pain medication that we wouldn't want you to be getting in the shower while you're taking that. So different labor positions. I kind of mentioned that we were going to talk about different labor positions. Labor positions are going to help that baby come down into the pelvis and get into the best position they can for birth. And that's our goal. And that's everyone's goal. So it also can, labor positions, sometimes we're changing your position to make your contractions more effective. And you may not like that. That actually may not feel the best to you. But if you're going to have a contraction, they might as well be as effective as possible. Sometimes we're changing your position to help with the pain. Does that feel good? So sometimes we're changing your position with that. Sometimes we're changing your position because the baby is telling us, I don't like this position, so we change your position to help with that baby. So maybe something on the fetal monitor is telling us, hey, you know, I'm not liking this. Can you help me out here? And so then that's our first intervention, is to change your position. It's very simple. It's non-invasive, very, very easy thing to do. Of course, we want to make sure that mom is active in her labor and is an active participant. I like this picture. If you kind of look at this picture, it shows how leaning forward helps that baby to be in a face down position. And I think in the video, it also shows that. So kind of pay attention to that. Basically, when you're leaning forward, when you're leaning over, leaning forward, the heaviest part of the baby goes to the bottom, which is going to be their back and their spine, which in turn makes them face your back. Okay. So, which is what we want them to do, and that is going to help with that. So let's just kind of watch this video about different labor positions.
Using different positions during labor and pushing can increase your comfort level and help your baby get into position for birth, which can make your labor go more quickly. When you're lying down, it can be harder for your baby to move down into the birth canal. A shawl known as a rebozo or a fabric belt can be used to support you in certain positions. This animation shows how your baby is positioned inside of you. When you use an upright or forward-leaning position like this one, gravity helps your baby rotate and descend, both of which need to happen before he is born. These positions are all good options: sitting, standing, squatting, hands and knees, and forward leaning. If you're more comfortable in bed, try lying on your side instead of your back. You'll probably try a number of positions during labor. Alternating positions manages the discomfort and helps your baby move it to the birth canal. Keep in mind that if an epidural is in place, you might not be able to use positions that are outside of the bed because your lower body will feel numb. You can add a calming, rhythmic movement to almost any position you use. Try rocking your pelvis while on your hands and knees, walking instead of just standing, or slow dancing with your partner.
There were a lot of positions that I expected to want to be in because they were comfortable when I was pregnant. But when I was in labor, it hurt way more to be on my hands and knees. The thing that I found worked the best, and I think throughout the entire labor, was the birthing stool. That something about sitting low and letting my bottom hang on it was much more comfortable.
All right, so I like those animations kind of showing you how the different labor positions work. And try the different labor positions. Maybe because you didn't like them earlier doesn't mean that you won't like them this time. So we kind of continue to try different positions. There are different positions that we can do in bed also. Okay, so some different labor positions that we can do in bed: side lying. We can also do this position in bed, forward leaning. So sometimes we can have you actually leaning over or put the ball up on the bed. We can have you leaning over the head of the bed. Those are all options. Sitting or sitting on the birthing ball. So sometimes I'll have the rocker over. I'll have my patients sit in the rocker initially or sit on the birthing ball while they're doing that. Or we can make the bed into a sitting position. Hands and knees. So leaning on your hands and knees, sometimes you do get tired from sitting like this, but we can also, again, use maybe the ball to help hold you up or prop you up with pillows so that it's not as hard on your arms. All right, so squatting, sitting in a squatting position also works. So we can pull out the squatting bar. Lunging or having that one leg up. This position actually works really well for a baby that we have that's just, maybe their head is just a little crooked. We can't get them to be, to kind of rotate around. So having the one leg higher than the other works really well. You don't have to maybe do it as extreme as she is. She's obviously very flexible that she can get her leg up way that high, but that is something that to try. Slow dancing or leaning forward also works. We can also raise the whole entire bed so that you can lean over the head of the bed, put your pillow on it, and you can lean standing up and lean on the head of the bed to kind of relax your upper body. Some different things to do with the fitness ball are sitting, forward leaning, and then using the peanut. So also with using the peanut, this is a labor tool that is just almost standard now. This is the peanut, and it actually is shaped like a peanut. You can't really see it here, but it's shaped, you know, just like a Mr. Peanut is. What happens with this is this works very similar to when you have that one leg up or like in that lunging position. So we can straighten out this bottom leg and really hike this leg up. And some other positions that we can do, we can have you set up, put one leg over it. So there's many different positions that, that we can do to help with labor progress. So some things for back labor, some tips for back labor. That's always a fear, I think, of people, is having back labor. It is unfortunately pretty normal. Counter pressure is where actually you put pressure right above mom's, literally in her low back, right above her butt crack. And it's going to be a slow, steady pressure that you're going to push during the contraction. And so when she's having that pain, you can either do that when she's laying on her side, she can maybe be sitting on the ball, she could even be standing, that you can help her with this. And if you do this and it feels better to her, then we can continue with that. Hot or cold packs. So we kind of want to, you know, think back to the basics. Sometimes one works better than the other. So I usually will have people, you know, if the hot pack doesn't work, then I'll say, let's try cold, because actually cold helps to numb those nerves, helps numb that area. So sometimes people like one better than the other. And then the double hip squeeze. So a lot of times I kind of do the double hip squeeze with counter pressure. It's really hard to do for a woman, like for me, to do a double hip squeeze and be able to squeeze in hard enough on both of mom's hips to be effective. So a lot of times what I will do is I will do counter pressure and a double hip squeeze. So put one hand on her hip and kind of squeeze in with counter pressure, and that helps relieve some of her back pain. A lot of times when we start this, we have to kind of trade off with the support person. You're gonna feel like you're breaking her, you push so hard. But it can help her get through, and it might be something that we kind of take turns doing. So in the one video with Deborah, her support person decides to take a nap during transition. I wouldn't recommend that. They did have a doula, so they did have a backup person, but you know, you want to rest when she rests. So if she's able to rest, then support people, you rest. So things to do for long labors: rest if you can. If you're able to rest, rest. You cannot walk a baby out. You know, I've had patients come in and they have been walking for hours to try to get labor started or to help labor along. All it's going to do is wear you out. You know, rest when you can. Change positions. So again, I told you about that earlier. Change positions at least once an hour, if not more. Changing that environment, you know, I mean, maybe you just need to, you know, in some of the videos you saw that they maybe went on a walk outside, or they went out and walked in the hallway at the hospital. Staying hydrated. You need to drink. If you're not drinking, then you're going to get dehydrated, and the uterus does not contract effectively if it is dehydrated. So we need to keep that uterus hydrated, along with, you know, you need that and the baby needs that too. Sometimes your support people need a break. Of course, right now we're only allowing one support person with you, but you know, we take breaks and we take turns with your nurses. So if if support person needs a break, you know, we can step in and do what we need to do. Trying the new techniques. Kind of what I mentioned before is that just because you didn't like it the first time doesn't mean that you won't like it again. So try it again and be open. Partners, support people, rest when you can. You need to eat and you need to drink because she's not able to eat. So once mom's here, she's going to be on clear liquids when she's at the hospital. But support people, you do need to eat because we don't want you to pass out in the big moments. So we want you to remain nourished. You know her better than we do. So we want you to be the link in between us. If there's something that, you know, you think maybe she might like or doesn't like, then let us know, and that's okay. The last thing is, don't take things personally. It's labor. It's a very personal time. I don't think you can get any more personal than labor and birth. So don't take it personal. Don't repeat it. Let her know that it's okay. She's safe. She should feel safe, and she should trust you to not take it personally. I always kind of use the joke that whatever happens in labor stays in labor, kind of like Vegas. So, just let her know that it's okay, that whatever happens there. All right, I love this picture because at the bottom it has a cervix. So this is a uterus and it has a cervix. I think it's very cute. All right, so let's talk about medical procedures. So these are interventions. This is what we can do to kind of help you. So these are things like IV pain medicine, epidurals, and then second stage interventions. Let's talk some things about that. Do you have a plan? Okay, so you've probably heard things about a birth plan. Do I have a birth plan? It's kind of a, a topic. But what I want you to know is that your birth plan, it's not rigid. We don't want it to be rigid. Like, I must have this, this, and this. If you say that, then it's really bound to not happen. So what we want you to do is kind of have thoughts in your mind about how you maybe want things to go, but don't be unflexible. We want you to be flexible and kind of know that, at the end of the day, what our goal is to have a healthy mom and a healthy baby. No matter how we get that, that's our goal. A healthy mom and a healthy baby at the end of the day. And I think most of you guys would agree with that. All right. When you are thinking about your plan, make sure you've talked to your provider about it and make sure they're on board with that. Okay. When you do your pre-admission, visit, talk to them about that. I'm the one who does that, and I'm going to ask you those kind of questions. Other questions that we're going to ask you is, are you going to breast or bottle feed? Things about your newborn. Do you want a circumcision? Have you chose a pediatrician or a family care doctor to take care of your baby? Those are things to start, to also think about. All right, so when you're faced with decisions to be made, we want you to use your brain. So this is just an acronym to kind of help you remember that. But what that means is, what are the benefits? So if I do this, what are the benefits of me doing this? What are the risks? Okay, so you should always know the benefits and the risks. Alternatives, is there an alternative? So if I don't do that, is there anything else that maybe we can try? What's your intuition? What does your gut say? Is everything in your body saying, no, 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 don't do this? Well, then don't. So what's your intuition? I've had patients that are scheduled for inductions, and they call the night before and they're like, you know what, I just really, I'm having second thoughts and I don't want to do it. Fine, if it's not for a medical reason. If it's for a medical reason, then, you're really gonna have to talk to your doctor about it. And then you're gonna have to go through this whole benefits, risk, alternatives, those kind of things. And then the other thing is what happens if we wait? What if no, or not now, or can we wait longer before we do that? So these are just some things, you need to be involved in your care, and you need to be educated on the different things that are being offered to you. All right, so induction of labor. So induction of labor is when we're actually causing your body to go into labor. So there's different ways of induction, and there's different reasons. So reasons to induce you is that you're past your due date. We know that if you go, the placenta, the organ that is made to maintain the pregnancy, only lasts for so long, and going too far past your due date, it actually starts to get old and it doesn't function as well as your baby needs it to. So that would be a reason that the pregnancy is continuing longer than maybe the placenta is starting to show signs of not functioning as well, or maybe we need to deliver the baby before it even shows signs of that. The health of the mom or the baby is at risk if the pregnancy continues. So, we kind of have to weigh the risk and benefits. Does she need to be delivered? Examples would be high blood pressure or preeclampsia. Those would be reasons, because the only real cure for that is delivery. Your bag of water breaks and your contractions don't start. So that might be a reason. And we do that because we know that the chance of infection dramatically starts to increase the longer we go. So do we need to get this labor going and try to get you delivered? If your body's already close to starting labor, there might be some, non-medical alternatives that you can try to help your labor get started, along with just being patient and waiting. All right. So some things to kind of talk about is with induction is your cervix ready? If your cervix is closed, thick, and your baby is high into your pelvis, your body is not ready for labor. And so we're going into a situation that it's not a very favorable cervix. But if your cervix is dilated and starting to thin out and is soft, then we're going into a better situation for induction of labor. So you think about a cervix when I talk about a soft cervix or ripe cervix. So when fruit is ripe, let's say I have a ripe banana, it is softer than it is when it's unripe or firm. So that's what we're talking about, is our cervix. Is it ripe? Is it soft? And the reason that is important is because think of those contractions, the contractions pushing down that baby onto that cervix. And if the cervix is firm, is it going to thin out and open up as easy as if it was soft or ripe? So if I have a soft cervix and I'm pushing down against that, it's going to thin out much easier and open up. All right, so that is why we talk about the consistency of the cervix, whether it's firm or soft or ripe. You might hear us say all of those different words. All right.
A week before Nikaya's due date, she develops high blood pressure. Her doctor recommends that inducing labor now is the safest option for her and her baby.
Packed my bags and I mentally prepared myself. Then I went to the labor and delivery and they hooked me up to the monitors.
Inducing labor means using medical procedures to start labor. There are several medical methods used to induce labor. Sweeping the membranes is one. This is when your healthcare provider separates the amniotic sac from the lower wall of your uterus in an attempt to trigger labor-causing hormones. Another way is using a mechanical dilator, which is a device that is inserted into the cervix and slowly expanded. Your healthcare provider might also insert a ripening agent against your cervix, or give you an IV drug called Pitocin. This medication is similar to the hormone oxytocin, which women's bodies naturally produce during labor and birth. Inductions are more likely to be successful if the cervix is ripe, meaning it's ready for labor. A woman's cervix is considered ripe when it is soft to the touch, starts to thin, and begins to open. Your healthcare provider will examine you to see if your cervix has begun to ripen.
Are you ready?
Since Nikaya's cervix has not dilated yet, the midwife inserts a cervical ripening agent into her vagina. This is a tablet that will dissolve.
So it's this little tiny pill, and I put it in your vagina towards your cervix, and what it does is help soften your cervix so that when you do have contractions, your cervix will dilate and open. Okay? We can put that in every 4 hours. You have to stay in bed for 2 hours because we want it to dissolve and stay in your vagina. We don't want you to get up and have it fall out.
A cervical ripening agent alone might work to start labor, but in other cases, a cervix might not respond to the ripening medication at all. After spending the night in the hospital, Nikaya needs a little more help to get her labor started. So she is now given the IV drug Pitocin. Pitocin might be used after a cervical ripening agent has been given, as in Nikaya's case, or it might be used on its own.
Okay. So during that video, they talked about using cervical ripening agents and those kind of things. So we're going to talk a little bit about those on the next couple slides. But reasons to induce is for medical reasons. These are not reasons to induce, all right? So think about it, because anytime we are causing your body to do something, there's going to be added risk. So anytime we do something to you, there's added risk, okay? All right, so augmenting labor is causing your labor to help your labor along. So this is a labor that maybe has started and then kind of slowed down or stalled. And then we will give you Pitocin to kind of help that labor along. We should only do it if it's medically necessary because of course there's risk involved. If your labor slows down, we can always try unmedicated ways of walking, having upright positions to try to get your labor to continue to progress. So augmenting your labor is causing your labor to, your contractions to get stronger by using Pitocin to cause those contractions to get stronger and closer together and hopefully be more effective.
Nakaya's induced labor is now in full swing, and she requests an epidural.
All right, good to go. Success.
A few hours after receiving the epidural, her labor slows down. Augmenting labor means using medical procedures to cause stronger, more frequent contractions, with the goal of opening the cervix more quickly.
Okay, so you might feel pressure, like touching. Can you feel me touching?
Yeah. Am I doing good?
Yeah, you're 400.
Her midwife suggests breaking her bag of waters to try to strengthen her contractions.
And then I just kind of snag it with the end there, and it pokes a little hole. So you see that little...
Breaking the waters, or amniotomy, is often used to move labor along. It also allows the practitioner to assess the condition of the fluid. Breaking the bag of waters is relatively simple to do and doesn't hurt the baby. To most women, it feels similar to a pelvic exam.
Is it water?
Nice and clear, yeah.
Okay, good.
Did you feel it?
Yeah. Well, I didn't feel it pop, but I felt it come out.
To break the bag, your practitioner makes a small, painless hole in the amniotic sac with a long crochet-type plastic hook. As the amniotic fluid around your baby's head drains, her head drops against your cervix, putting pressure on it. This should help to open the cervix. This added pressure also makes contractions feel more intense. Practitioners generally wait until the head is low in the pelvis before breaking the waters. There are risks for you to consider before agreeing to an amniotomy. First, it does not always shorten labor. Second, once the bag is broken, there is an increased risk of infection. And third, the lack of amniotic fluid in the sac may increase the risk of fetal heart rate issues. Miramar has not progressed any more since the last cervical check.
And the other option would be starting an IV medicine to help your uterus along.
The Pitocin?
If you're okay with it, I would think it would be a good idea to pursue Pitocin.
Yeah.
Miramar discusses the benefits, risks, and alternatives to Pitocin with her doctor.
I was saddened to hear them, when they came in to talk to me about the Pitocin, weighing, the options and considering like what I wanted versus what, is best for me and my baby. We decided to just, go ahead with the Pitocin.
Pitocin, which is also used to induce labor, is a chemical made to imitate oxytocin, the natural hormone that triggers labor. Pitocin is usually very effective at starting or strengthening contractions. A pump controls the amount of Pitocin that Miramar receives through her IV. This allows the nurse to adjust the amount of medication as needed. Your baby's heart rate will be monitored continuously while you are receiving the drug.
All right. So just to kind of talk about everything again. Different ways of induction are stripping your membranes, and that would be something that you would talk to your physician about. Cervical ripening. So that is in the first little video, she talked about putting a very small pill up behind her cervix. And that is cervical ripening. So the goal of cervical ripening is to make your cervix soft. So if we have somebody that is past their due date and their cervix is still very firm, so a lot of times we will do cervical ripening. So we will bring them in the night before, have them come in, we will monitor them and admit them, and we will place cervical ripening agents. Different physicians use different kinds. There's the pill kind is called Cytotec. There's a kind of, looks like it's called Cervidil, and that one actually stays in, and that one's actually placed into your cervix and stays for 12 hours. And then it is actually attached to a string, and then we take it out. And then usually we'll start the induction process. So hopefully it has done its job. So there's different types of cervical ripening agents. But typically, like I said, we do those on the night before to kind of get your cervix ready for an induction for the next morning. Sometimes it causes you to go into labor, which is even better, that it actually will cause you to go into labor. Mechanical dilators are things like what we could use as like a Foley catheter, or they actually make mechanical dilators. But basically what this does is it you blow up a balloon. So this is placed up into the cervix, and you blow up a balloon with sterile water or saline, and what that does is puts tension and extra pressure onto the cervix and actually helps to open up that cervix mechanically. Other things for induction is breaking your water. It just kind of helps having your water broke. You know, the important thing is that making sure that the baby's head is well applied to the cervix before that happens. And so that is something that your provider is going to be checking for. And Pitocin, causing your body to have contractions. So Pitocin causes your body to have contractions. Now, whether those contractions are effective and strong enough, those are two different things. So sometimes we can give a patient Pitocin, and if their body's not ready to accept it, their receptor sites are not available, then they never do have painful contractions, which in turn means they also don't make cervical progress. So, you know, all of those things need to be considered when we're considering inducing somebody. All right, so other interventions are IV pain medicines or IV fluids. When you're in labor, we do actually put an IV in. Now, whether we hook it up to fluids or not, that just depends. If we are doing something to you, like inducing you or giving you pain medication, those kind of things, then we will have it hooked up. But if you might be somebody that wants to move around and you're drinking and we're not giving you anything, then we can just have the access there and not actually have it hooked up to the fluids, as long as you stay hydrated. All right, so other things that we use the IV for is to deliver Pitocin to you, to induce you, to give you antibiotics, possibly, especially for a mom that might be GBS positive, that we would need to give her IV antibiotics during labor. Or other medicines like pain medication, or to also help prepare for an epidural. All right, but you can stay hydrated just by simply, drinking helps you maintain. And remember how important it is that you are hydrated, so that uterus can contract effectively. A dehydrated uterus does not contract effectively, and is just going to helps it could possibly slow your labor. All right, so other interventions is monitoring. So when you come into the hospital, we are going to monitor you and the baby. So external fetal monitoring is what we're seeing here in this first picture. And the first belt that you see on the top of her abdomen is going to be the one that's probably measuring contractions. And on that monitor, there's a little nub that is on the bottom side. And when your belly gets hard or contracts against it, pushes against that little button and reads a contraction on the monitor. Okay, so it's simply just a sensor that can tell if your stomach is getting tight or if it's your stomach is soft. It is only going to show us how often the contractions are and how long they're lasting. It doesn't show us any strength or intensity. Okay, so how we show that is, you know, what you're telling us, and then by us touching your stomach. A strong contraction is an unindentable contraction. So what that means is that we can't push in on that. Your stomach is that hard that we cannot push in on it. So what we say is a strong contraction would feel like your forehead. So your contraction is that strong that it feels that hard like your forehead does. So that would be a strong contraction. The monitor on the bottom is probably the one that is doing for the baby. And so what that does is picks up the baby's heart rate and reads on the fetal monitor. Anywhere from 110 to 160 is normal for a baby, and baby's heart rates vary all in between that. And your nurse and your physician have all gone to have lots of education about fetal monitoring and what that indicates to us. So we don't want you to be too worried about it, but just let us watch it. When you're on the fetal monitor, know that there's always somebody watching the monitor. We have centralized monitors, so there's always somebody watching it. So, you know, try not to worry about it too much. All right. In this next picture, it just shows that the orange numbers are the baby's heart rate. The green number is a contraction. Now, that number has no influence on the strength of the contraction. It's just that it's going up and down. All right, so some people, just depends on where that monitor is placed on their belly. Sometimes those hills that are shown may not show up as high as maybe another person's may. So what I'm talking about here is this is showing a contraction. Some people will show like this and it looks like a very strong contraction and they're smiling. They're not having any pain. Some people, the contractions may barely be showing and they're actually in active labor. So it really is, does not show strength. So the external monitor does not show how strong those contractions are. All right. So internal monitoring. So anytime we're monitoring, we're always monitoring your uterus, the contractions, and the baby. So these are the two different ways that we can monitor internally. So the first one is the IUPC, or the intrauterine pressure catheter. And what that does is it actually, I talked about that we cannot measure intensity with the external monitor. Well, with the internal IUPC, we can measure the actual intensity or the strength of the contractions. So what this does is it goes up next to the baby's head into a pocket of fluid, and there's a sensor on the end of it. And that sensor actually can measure how much pressure is inside the uterus during the contraction. So, and then that is measured on a graph, and we can actually tell the intensity of the contraction. And we know that with certain intensity of contractions, that your cervix should be making change, should be changing. So this might be something that we do if we have a mom that's not making cervical change and we feel like her contractions are strong enough. Maybe we've already started Pitocin. And so she's on Pitocin, we're causing her contractions to be strong, or what we feel like they are strong, but she's still not making cervical change. So we're trying to figure out, are her contractions strong enough? And this would be the way that we could figure that out. The fetal scalp electrode is the other one. What this is a monitor that is actually attached to the baby's head. It is attached under the first couple layers of skin. So it does break the baby's skin. Of course, either one of these we're not going to use unless we really feel like it's necessary. There's risk, of course, involved with both of these being used. A scalp electrode would be used if we really are unable to monitor your baby's heart rate. So we would try to place this to see if we can get your baby on the monitor to check to make sure that your baby's okay. Of course, risk for both of these are going to be risk of infection because, you know, it's an internal monitor. And, you know, increased risk of infection is the major, as the biggest risk of both of these. All right, so let's start talking about pain control. I know you guys have been waiting the whole time about this. So the first thing we're going to talk about is analgesic, or what we would maybe think of as IV pain medicine. So this is going to be a narcotic that we can give you in your IV. Can also be given in a large muscle, so we can also give it as a shot. This is a systemic medication, so it affects your whole body. So it's not just a portion of your body. So with that, you're going to have the woozy feeling because it does go into your bloodstream. It does affect your whole body. So this is going to be something that lessens the pain without causing numbness. It's just going to take the edge off. This is something that we can be given soon after it's asked for. Nurses can give this. So let's just kind of watch this little video just about IV pain medicine.
Breathe.
Janine's labor started yesterday afternoon. She labored at home for several hours before it was time to go to the hospital. It's now early morning and she is exhausted and considers pain medication. She requests an analgesic, which is a medication that affects the whole body. It dulls pain sensations, but does not get rid of the pain completely. The analgesic is either injected as a shot in the thigh or buttocks, or given through an IV line.
You probably have just enough time to have one dose of some medication in your IV. That will just take the edge off. So it's your choice as far as what you want to do.
So the reason why I was open to the IV drug is because the doctor had said that it was a way to kind of take off the edge. And I needed to take off the edge, and I felt like my breathing was doing pretty good, but it was just so painful.
So after Janine took the IV drug, I experienced her as more calm, more collected. Even though she was still in pain, she wasn't as stressed. So I noticed a difference.
It's recommended that you consider analgesics earlier in your labor in order to reduce these effects on the newborn. For this reason, many hospitals have policies regarding when they allow you to receive analgesics during labor. For Janine, the analgesic wears off and she progresses into pushing and birth several hours later.
Good job. He's coming. He's coming out. He's out. Okay. His head's out.
Look down. Look down. Look down. Your eyes open. Your eyes open. Your eyes.
Yeah, look at him. Look at him.
There you go.
Good job.
Up here.
When the baby came out, it was a relief. I'm like, okay, yes, it's done. We did it.
Oh, yeah.
You know, I wanted to look at him. I wanted to touch him. I wanted to hold him and see if he was okay.
All right, so they do kind of talk about that some hospitals do have policies. So what they were talking about is that because whatever we give you in your IV also goes to the baby, so the side effects of those medications also have side effects on the baby. So if we think you're going to deliver within the hour, we will try not to give those to you. If it happens and we give them to you and you deliver within the hour, we do have medications that can help reverse those effects, but we really try hard not to do that. Or sometimes, you know, we think you're going to deliver in the hour and you don't, and then, but we're trying to do our best to try to judge that. So the advantages of IV pain medicine or IM pain medicine, it can be given soon after it's requested. You start to feel the effects of it within 10 or 15 minutes after it's given. It doesn't numb you, so some people see that as an advantage, some people see that as a disadvantage. It just kind of depends. Disadvantages, it doesn't provide a total pain relief. So if you're looking for that, that's not what you're going to get with this. It can cause drowsiness, disorientation, itching, or nausea. So you get that feeling because you've received a narcotic. So you're going to have that woozy feeling that you might get. It can slow your breathing or lower your blood pressure. That can be a positive. It depends on what that was before. So if you were breathing too fast or too tense ahead of time. And some of your mobility might be inhibited because you're not able to get up on your own because of that woozy feeling. So you kind of have to think about that. IV pain medicine is something that's really hard to judge. Sometimes it's really hard to know what kind of effect it's going to have on a person. Some people, we give it to them and they go to sleep and it works great. Some people, we give it to them and they act like I didn't give them anything at all. So as far as how do I know how you're going to act with that, I have no idea. But I know that the first time I give it to you is how you're going. If it works for you, then it works. But if it doesn't work, it's not going to work the next time. So we might need to move on to another option. Side effects on the baby, I talked about earlier, is that can be sleepy, have difficulty breastfeeding at first. It can actually slow their breathing and reflexes. So with that, because it has a respiratory depression side effect, that is why we don't want to give it to you within that first, if we think that you're going to deliver within that hour. So because we want our babies to come out and breathe. So if this has a respiratory side effect, then that can help decrease that. So we really try hard to not do that. So of course, we try to avoid giving this just prior to birth to help reduce these effects. All right, epidurals. So epidural is going to be the best pain relief that you can get in labor. It's given by an anesthesiologist here at Liberty. It's a regional anesthetic, so it covers a region of your body. So different than the systemic medication that covers your whole body. This is just going to cover a region of your body, hopefully, that we're going to cover your uterus, your abdomen, and your lower back, so where you need it. We still want you to feel pressure with contractions, but we don't want you to have all over pain, okay? The epidural takes about 15 minutes to administer. And something to note is from the time that you ask for an epidural to the time that you're comfortable is usually about an hour, because prior to giving an epidural, we have some preparation to do. We need to give you lots of IV fluids to help with side effects from the epidural. So, and that takes time to actually administer. So just know that it's not a short process. It's not something that's going to happen with the snap of a finger. So. All right, so the placement of the epidural is actually placed below where the spinal cord ends. So let me just kind of get my highlighter here. So the white bright line is where the spinal cord is, and down here is below where the spinal cord ends, and the epidural is actually placed below where the spinal cord ends. And into the epidural space, which is one step out from the spinal space where your spinal fluid and your spinal cord is located. So it's actually one step out from that, which is about the width of a credit card, okay? So that is actually where your epidural is placed. All right, so let's just kind of watch a video about the epidural.
As you follow Maramar's birth story, you'll learn more about epidurals. She went into labor about 8 hours ago. Now she is dilated to 5 centimeters and requests an epidural.
The reason we chose to get the epidural was just really the exhaustion that I felt.
Maramar receives fluids through an IV before getting the epidural. procedure is performed by an anesthesiologist or a nurse anesthetist and takes about 15 minutes to complete. To start, the anesthesiologist washes Miramar's back with an antiseptic cleanser. Then he injects a numbing medication into her lower back so she doesn't feel the epidural needle. This animation shows where the epidural is placed. You can see that the injection site is below the spinal cord, so there is almost no risk of the needle puncturing the cord during the procedure. This image shows you a closer view of the administration area. The center column is the sac that contains the spinal cord and spinal fluid. The gray area that surrounds it is the epidural space. To get into position, you will curl forward or hug a pillow to make more space between your vertebrae, which are the bones of your spine. The epidural needle is carefully placed between the two vertebrae and into the epidural space. A catheter, which is a thin plastic tube, is threaded through the needle. The needle is removed, leaving the tube in place. The anesthesiologist then injects a test dose of medication through the catheter. The catheter is taped to Miramar's back, and medicine flows through the catheter. It takes about 15 minutes to feel pain relief. Once the epidural is in place, pain should be reduced by numbing your belly, lower back, and vaginal area. You may still feel a slight amount of pain, pressure with contractions, or pressure on the pelvic floor as your baby moves down. However, your baby won't feel any numbing from the medicine.
And afterwards, the contractions were pretty much back to how it was at the beginning. So I was able to get some rest after that.
Having an epidural brings about an immediate increase in using more medical equipment during your labor. You're continually monitored after receiving an epidural. In addition to fetal monitoring, the staff monitors your blood pressure and the amount of oxygen in your blood for the remainder of your labor. Since your legs might also feel numb, and you may not feel when your bladder is full, you'll need a urinary catheter. This is a flexible tube used to drain urine from your bladder. One downside to having an epidural is being stuck in bed and not being able to use more productive upright labor positions. But with the epidural in place, you can still move from side to side once in a while. Changing positions helps your baby rotate into position for birth.
All right, so that kind of shows us some good pictures about the epidural placement. All right. And here's some other pictures just so we can kind of look at it a little bit closer. So the needle part actually comes out, and then a small plastic tube is left in your back and then taped down. And we continue to give you medicine through that small plastic tube, like a continuous infusion, kind of like an IV. And so a lot of times people will say my epidural wore off, things like that. So something else must have happened at that time, because it is a continuous infusion. All right, so the advantages of an epidural is it's the most pain relief that you can get in labor, can allow you to rest, and it doesn't affect mom's mental state. So she doesn't have that groggy feeling after getting it. The risk can be that it can offer incomplete areas of relief. So, that can happen. We can do things to try to help prevent that or to try to help fix that. Can lower blood pressure and cause the fetal heart rate to drop. That is definitely a risk. And that is why we give you a lot of IV fluid ahead of time, because a normal side effect after an epidural, because of the medication that is given during the epidural, and because we are also having the whole lower part of your body relaxed, can cause your blood pressure to drop. So if you think about the pressure inside the vessels is less, and that causes the blood pressure to be less. If we give you a lot of IV fluids during before that is before the epidural is given, then there's going to be more pressure inside the vessels and help decrease that side effect of a low blood pressure. It's something that we watch for and we actually expect it to happen. So we take your blood pressure very often after an epidural until it's stable, and then we will slowly space that out to kind of watch that. The reason that the fetal heart rate may drop afterwards is because of the blood pressure drop. So if we can control your blood pressure, then we can help control the baby's heart rate. And we also have medications that we can give you to help bring that blood pressure back up. Again, it's a normal side effect. It can also cause some shivering, fever, itching, or nausea. The nausea is usually caused from the lower blood pressure. So once we fix that, it helps fix the nausea. The itching can be from a medication that they give. Some of the medications have a side effect of itching. It's not an allergic reaction, but they do have that. It does go away. It usually only lasts the first hour. The shivering, sometimes it's hard to tell because a lot of times when people get their epidural, they also go through transition. And in transition, a lot of times our patients have shivering or nausea during that time too. So it's really hard to tell. You're going to have soreness in your back. You know, they poked a needle in your back. So you might have some soreness or some tenderness in your back. Rare but serious side effects are on the consent form. So I know a lot of times people are always worried about that. Effects on labor. So, you know, the more we do to you, the more interventions that it's kind of a vicious cycle. So we're going to be monitoring you continuously. You're going to need to stay in bed. And with that, you're going to need a urinary catheter to empty your bladder because you're not going to be able to empty your bladder. The good thing about that is that you don't feel that because you have an epidural. So it's a good time to have one if you're going to have one. Something to kind of remember is that it's really important for you to keep your bladder empty because a full bladder just blocks the way. So having a full bladder just blocks the way of that baby's head. So we want to make sure we keep that bladder empty. It can affect mom's labor progress. It just depends on when it's given. And then pushing. I mentioned earlier that if you don't have an epidural, you're going to push with or without us directing you. It's just, you do it instinctively. So with an epidural, you know, sometimes it does take some more coaching and some learning on how to push. So some tips for epidurals. All right, so wait until you have regular contractions. Make sure you're in good active labor before you get an epidural. You know, things to ask, is the baby's head nice and low? Those are things to maybe ask. Rotate from side to side. So this is something we are going to be doing because the medication that is given in your epidural goes to the low side. So it's gravity dependent. So if I have you on your left side, if I kept you on your left side the entire time, your entire left side is going to be numb and your right side is not. So we need to rotate you so that that medication remains equal, so that the numbing remains equal. Of course, and that's also going to help with your labor. So, you know, that's another reason that we're always changing your position, is to help labor progress. Once you're fully dilated, allow that baby's head to descend further before pushing. So a lot of times when you're fully dilated with an epidural, what we'll do is we will have you try to push and see how you do. If you push and the baby moves great and you make great progress, we'll just push and have a baby. If not, a lot of physicians will have you labor down. And what that is that we will wait to start pushing until maybe you feel some pressure with the contractions, or the baby's head gets low enough and we'll try to push you again and you start to make more change. All right. So just remember, anything we do to you, there's going to be side effects and there's risk involved. So, all right. So second stage intervention. So this is during pushing and delivery. So these are things that can be done to help the baby be born quicker if needed to be. All right. So what these are is going to be forceps or vacuum. Different physicians use one or the other, and it's really, you know, what they're comfortable with. They both have side effects. They both have risk, I should say, not side effects, but they both have risk for their use. This is something that's not going to be used because mom doesn't want to push. This is something that is going to be used because we need to get the baby out as fast as possible. And even in our fastest C-section delivery, it might take 10 minutes. Well, 10 minutes is a long time to wait if you are actually at the delivery stage, and you can use an intervention like vacuum or forceps to get the baby out. Your physician is going to talk to you about this before they use it. And of course, talk about the risk. So the risk for both of these, there's going to be risk of bruising on the baby's head, trauma to the mom's vagina, or the area between the vagina and the anus, or the anus, just because that's one extra thing that's added in there. They can also cause temporary nerve problems to the baby's face. That is more with the use of forceps, because of where they're placed. There could be swelling and cause swelling on those nerves that can cause nerve damage to those areas. Again, this is something that we're not going to use just because. Episiotomy. So episiotomy is when you actually need to make more room. And so they will enlarge the area in between the vagina and the rectum. Something that is only done if necessary. And most physicians are really trying not to do episiotomies now. But this is definitely something, you know, to talk to your physician about. I don't want an episiotomy at all costs, or I'm okay with an episiotomy. As far as how they heal between a tear and an episiotomy, there is literature out there that shows really, you know, the fight for each side of that. So there's a lot of interventions. So there's induction, augmentation, IV medicines, epidurals, monitoring, second stage interventions, and then the last major intervention is going to be cesarean section. So let's talk about that. All right. Right, so remember, if you don't know your options, you don't have any. All right, so let's talk about C-sections. All right, so C-section is the cesarean birth, surgical delivery of the baby through an incision of the abdomen and uterus. All right, so the national average is about 30%. The reasons for a cesarean fall into three major categories, and so this is kind of how we're going to talk about it. Is it planned, unplanned, or an emergency? So planned cesareans. So this is something that you're going to know ahead of time. This is something that's scheduled. And the reasons for that would be maybe your baby is breech or anything other than head down. So your baby's transverse. Another reason for a planned cesarean is that you're a placenta previa. And that would be something that you would already know. So a placenta previa is basically that the placenta, okay, so see this placenta right here, is actually blocking, this is your cervix, okay, so blocking the way of the cervix. So what happens if your placenta comes out before the baby? The mom is not, or the baby is not getting any perfusion. So they're not getting anything that they need. The other thing that you can think of is if we were to go and check you, and as that cervix starts to dilate, that's going to actually tear that placenta. So a vaginal birth is not possible with a placenta previa. Other reasons is mom is having more than one baby. Twins can be born vaginally as long as at least the first baby is head down, okay? And then a medical condition in mom or baby that is recommended for a C-section. or mom has had a cesarean birth before, and she chooses to have another cesarean birth, okay? Or if she doesn't choose a cesarean birth, she may choose to try to VBAC, which is a vaginal birth after cesarean, and that would be something to discuss with your physician, whether you are a candidate for that or not. All right, so unplanned cesarean birth is you're in labor and labor is going along, but every time you have a contraction, your baby's heart rate goes down and your baby's not tolerating labor. And it's really hard to have a vaginal delivery without contractions. So then our only option would be a cesarean. Labor is not making progress. So we've tried position changes, we've tried Pitocin, we've tried everything, and labor just still isn't progressing. And maybe it's just the position of the baby. Maybe that's something that we just are unable to tell. Baby moves into a position where vaginal birth is difficult or impossible. So the first thing I think about with this is possibly a face presentation. So that baby goes ahead and really extends its head all the way back and its face is presenting first. It's dangerous to deliver a baby in a face presentation because of the outstretched neck. So a C-section would be the best choice for delivery. Baby's head's just not fitting into the pelvis. The baby has not come into the pelvis at all. Maybe the head is bigger than your pelvis, okay?
First-time parents Louisa and Jessie planned to have a vaginal birth. About a week after her due date, she still has not gone into labor. Her midwife scheduled an ultrasound to check on the baby.
A couple minutes into the ultrasound, we could tell that something wasn't quite right. She let us know that she was searching and she wasn't finding any fluid, that she was looking and there wasn't much to be found. And the midwife said, you know, just go ahead and walk over to labor and delivery.
Louisa and Jessie go to the hospital and get settled in. Because of the low amniotic fluid, the midwife suggests they induce her that day to try to get labor started.
We'd hope to get it to thin out a little bit and open up a little bit, which means that we...
The midwife inserts a cervical ripening agent into her vagina. This is a tablet that will dissolve and help to open her cervix.
We'll still have a normal birth. She'll just have to be induced, which, isn't exactly what we wanted to do, but it'll still work out fine.
I was nervous and excited and also felt very unprepared. We thought we were just going to an appointment, and so I don't think I even brought my purse with me to this appointment, so we had nothing with us, and my meticulously packed labor bag was still at home.
Yeah. See you in a little bit.
All right.
Jessie goes home to get the hospital bag and then stays with Louisa that evening in the hospital. The next morning, Louisa is having very mild contractions.
Your baby's heartbeat's doing just fine.
But no real progress is being made.
Nice job breathing.
The midwife talks to Louisa about using Pitocin to help strengthen her contractions, and Louisa agrees. A few hours later, the baby's heart rate begins to fall, and Louisa is given oxygen to see if that helps.
Okay. What I want to have a very real conversation about is that
Because the baby shows signs of fetal distress, they discuss the possibility of cesarean surgery.
I think, honest to goodness, that our safest bet is to just have a baby. And by that, I mean, I think that we're going to need to have a cesarean birth here this afternoon, and sooner rather than later. Okay?
I just knew that, the most important thing was to have her safely, and the fact that she wasn't doing well made me feel like, okay, well, whatever we have to do.
Yep, we are gonna have a baby, right? Right?
Louisa signs the consent form and is prepped for surgery.
Like a really cart thing for your steps that it all stays with you too. Yep.
Thank you.
Cesareans are performed in the operating room, and at least one support person is usually allowed to accompany the mother. Before joining Louisa, Jessie changes into scrubs because the operating room is a sterile area.
You ready, sister? Let's do this. Let's go meet your baby.
Her head's out. I told her when I saw her head, Sophia's head coming out, and there's one part where Louisa asked what was going on because she felt like a whole lot of pressure, and they were actually like pushing Sophia out, and it was just like crazy to me.
I saw Sophia for the first time when they were walking her over to the warmer, and so they had let me know that they would dry her off first because it was so cold in the operating room before they could give her to me. And then as soon as she was dried off, they gave her to Jesse, and he brought her over. And then the nurse helped put her on my chest after he brought her over.
Jessie and Louisa have a healthy baby girl who weighs 6 pounds and 11 ounces.
All right, so that would be a pretty typical story of an unplanned cesarean birth. So an emergency C-section. So this would be something that is an absolute emergency. Some reasons for that would be a cord prolapse. So what a cord prolapse is that the umbilical cord comes out before the baby's head, and then the baby's head actually comes down and occludes the blood flow to the baby. So right here, kind of as the baby comes down, it will pinch off that blood flow to the baby. And so that would be an absolute emergency. And what would happen in this situation is that we would check your cervix. We would find that we do have a cord prolapse. And what that person would do is they would actually push the baby's head off the, just a gentle lift off of the cord, and they would stay there until the baby's out. So it would be just like a fire drill. Everyone would come into the room. All hands would be on deck. We would prepare you for a cesarean section. And again, that person would continue to hold the baby's head off the cord until that baby is born via C-section. All right, another reason would be a placental abruption. And that is where the placenta pulls away from the lining of the uterus for one reason or the other. And with that, as I've talked about before, how important that placenta is that if once that uterus starts to pull away from the inside of the uterus, or once that placenta starts to pull away from the inside of the uterus, we don't know how much that baby is getting. So that becomes an absolute emergency in that case. A uterine rupture. A uterine rupture is actually where the uterus actually ruptures or actually tears, and that would be an emergency. Severe fetal distress. So in the video before, the baby was showing signs of not tolerating labor, but obviously it wasn't an emergency. This would be baby's heart rate goes down, and we have done all of our interventions, changed your position, possibly put oxygen on you, giving you IV fluids, done everything that we know to do, and we still cannot get that baby's heart rate to respond, then our only other option is to get the baby out by C-section, and that would be an emergency. Luckily, emergencies only occur in about 1% of births, so that's the good thing. In an emergency C-section, or let's kind of talk about the differences between an emergency C-section and a planned or unplanned cesarean. So with our anesthesia, we can do, if it's planned or unplanned, if we have time, the anesthesia can be an epidural. So if you have an existing epidural, the anesthesiologist can give you more medication so that you can tolerate surgery. If you don't, then they can do a spinal, which is very similar to the procedure of an epidural, except for nothing sticking near one step for final space. Inject medication comes out of your back. It works fast. It's going to give you the numbing and numbing medication that will last through the surgery. And then we can also give you, with that one-time shot, medication that will last, that will give you good pain relief for 12 or 24 hours after the surgery. And sometimes they do a combined technique where it's a little bit of both. Usually at our hospital, we see the epidural or the spinal. If it's an emergency, so when you have an epidural or a spinal, you're able to stay awake because we want you to stay awake, and that's always our goal, to be awake for the birth of your child. But sometimes we just don't have time. With both of those, it's going to take time. It's going to take, at least maybe 10 minutes to perform the procedure or to get you numb through the epidural. In an emergency, we don't have time for that most of the time to be able to dose an existing epidural. If it's a true emergency, we're going to need to put you to sleep. If we have to put you to sleep, then nobody is allowed to be in the operating room with you. If you're able to stay awake, one person is allowed to be back there in the operating room with you. Again, true emergencies don't happen very often, but when they do, it is a true emergency. So. All right, so this is just kind of a little animation about what a C-section is.
This animation will help you understand the cesarean procedure. In order to reach the baby, the doctor makes a 4 to 6 inch horizontal cut to the abdomen, just above the pubic hairline. The abdomen is made up of an outer layer of skin and an inner layer of fatty tissue. The abdominal muscles and the uterus are beneath. During surgery, the layers of skin and fatty tissue are cut. These top layers are spread apart to reveal the abdominal muscles. The doctor separates these muscles by hand. You won't feel any pain when this happens, but you may feel tugging or pulling sensations. Next, these outer layers are retracted to expose the uterus. The surgeon makes another incision in the uterus and breaks the bag of waters if it hasn't already broken. The surgeon guides the baby's head away from the pelvis and toward the surgical opening, while an assistant applies pressure to the abdomen. Once the baby's head is out, the surgeon gently pulls the baby through the opening and she is born.
All right. So like I said, that's just a little animation about it. So let's just go through the advantages and disadvantages of a cesarean. So it's a life-saving procedure. So it's something luckily we have if a vaginal birth is just not safe or it's just going to take too long. It's the quickest way that we can deliver. And of course, it's a relatively safe procedure. It is something that's been around for a long time. Disadvantages, of course, are going to be infection. There's a higher risk of blood loss, a higher risk of having blood clots in mom's legs just because she's not up moving as fast. Although we do get you up and start moving you pretty fast after a C-section to help prevent that. Future pregnancy problems. So you do have a scar on your uterus that is going to always be there. So that can cause problems with future pregnancies. Injuries to organs. So of course, anytime we're having a surgery like that, it is an open abdominal surgery. So there can be injuries to other organs. And of course, the recovery is more painful and it's harder because it is a major abdominal surgery. So it's not something that we do just because there are risks to having a C-section compared to a vaginal delivery. Disadvantages to babies. Babies that are born via C-section have usually have a little bit harder time transitioning. Even though we try our best to mimic the vaginal birth process, they still usually have a little bit more breathing problems. They have more mucus, so they will spit up more mucus and are a little bit spitty after delivery. So something that we always are watching for. And typically they do have lower APGARs. There is always a risk of injury, but that is very rare. So what are some things that you can do to reduce your risk of C-section? Enter labor in good health. So we want you to be healthy. We want you to eat right and exercise and, you know, stay a healthy weight. People let labor start on its own. The less interventions, the less that helps decrease your chance for a C-section. Having continuous hands-on support, having somebody there that's supporting you, and using those upright labor positions. For an epidural, wait until labor is well established before we start with that chain of intervention. So like I said, once we start intervening, then it does become a vicious chain and kind of a cycle. With having a C-section, of course, we are always trying to, our goal is to keep you awake, to have your support person back there. We can do all of those things to help you with that. You can take pictures. We just ask that you don't take pictures of any procedures. Holding your baby, we can do skin to skin in the OR, just like this lady does. We can lay that baby on your chest and have skin to skin while the cesarean section is getting finished up. And of course, we would try to get you to breastfeed as soon as possible. All right. So all of us have different goals. So, you know, she's asking you, are you hoping for a boy or a girl? Well, I don't know, as long as it has 2 arms, no legs, 3 belly buttons. You know, we all have different goals in mind. All right, so let's talk really quickly about postpartum. So postpartum, what happens with postpartum is what is being shown here is on the left-hand picture is that person is feeling for the patient's fundus or the top of their uterus. So they're feeling to see if that, I talked about that it should feel about the size of a softball or a small cantaloupe, and it should be nice and firm. So that's what that person is doing. A sitz bath is something that we can use for a sore perineum or a sore bottom is kind of what you'll hear us talk. But I will say that we use these less and less because of the handheld shower heads. And if you have a handheld shower head, this can do the same thing. It's just water running over your perineum to help soothe. So lochia is vaginal bleeding, and it's not a period. It is from the open wound that's inside your uterus. So I talked about the open wound from where your placenta detaches, and it's an open wound of millions of tiny blood vessels that are now exposed. So that is what the lochia is from. It's normal to have it for 3 to 6 weeks after birth. Nothing is allowed in the vagina, so you have to use pads, no tampons. And it changes in color from bright red to brown to almost no color at all, just like a period would, but over a much longer time. So things that are going to be given to you while you're here in the hospital is going to be pads. So let's kind of talk about our pads. So this is actually the smaller of the 2 pads that we give you, but they're much bigger than what you're used to. We give you very, very large pads. The first, probably I think we give you 3 or 4 of those, and you're going to need it. It's going to be more bleeding than what you're used to. And so we will kind of educate you on that and kind of what's normal with that. Then you'll move on to these peach type pads, which are still going to be much bigger than what you're used to having. And along with that, you're going to be wearing these fancy net panties that we provide you with. So you're going to put those, your pad and your net panties. And then what this is down here is an ice pack that it looks like a pad. And so you can put your pink pad on and then your ice pack. And then this is your peri bottle. So every time you go to the bathroom, you're going to fill this up with warm water. and you're going to squirt off from front to back every time you go to the bathroom, and you're going to change your pad every time you go to the bathroom, even if you don't think you need it. If you need to dab, you can use a little bit of toilet paper, but we just don't want you wiping a lot. So you're going to clean yourself off with the water and squirting off from front to back. These down here are witch hazel pads, or Tux pads would be the brand name of them, and they are used they're very soothing. So witch hazel is very soothing, and it helps decrease swelling. So we can use these. They're not just for hemorrhoids. So what we do is a lot of times we will put your ice pack down, and then we will line it with Tux pads to kind of put up next to your bottom to help with that. A lot of people really like these. This is Dermaplast. This is what we're currently using, but sometimes we change brands or change different products. But basically what it is it's some kind of a numbing spray that you can actually spray onto the area, and it helps with pain relief. So these are all things that you're going to get at the hospital. So every time you go to the bathroom, it's a little bit more of a adventure than maybe before. We're going to help you with this the first time and kind of teach you what you need to do and how to do it. While you're in the hospital, you're going to have different ways of pain control. You can have oral pain medicine that can be narcotics or just simple Tylenol or ibuprofen that you can take. Other ways for pain control is going to be using the ice packs, the Dermaplast, the Tux pads. And the other thing that I didn't show you is a comfort cushion. And basically what that is a blow up. It looks like a donut that you can sit on. That might be something that you might want to try if you're having a lot of pain in your perineum. Other things to remember is that we really want to control the swelling of your perineum. So swelling goes to the lowest point. So the more that you're sitting upright, if you're having a lot of perineum pain, try laying down, laying flat, laying on your side as much as you can to help control that pain. A normal stay for a patient, a vaginal delivery is 48 hours, not including your day of delivery. So if you delivered on a Monday, you would go home on a Wednesday, sometime that day. For a C-section, it adds 1 day. So 72 hours, not including your day of delivery. So if you delivered on a Monday, you would go home on a Thursday. While you're in the hospital, once you're on a regular diet, you can eat. Usually this is the question I get. You can eat whatever you want. So if you want to eat something that is from outside, that is fine. Usually a vaginal delivery, you're on a regular diet right after delivery. For a C-section, you're on a regular diet usually the next day, because we have to wait for your intestines to wake up and be ready to digest food. If we put food in there before it's ready, then it's just really going to cause you problems and you're going to regret eating that. All right, some reasons to call the doctor postpartum, and you'll get these all written out. You'll get papers that you'll get. But reasons would be a fever over 100.4, foul smelling or vaginal discharge. So this is not going to be, we know what a normal vaginal discharge smells like. This is something that is foul smelling, and we're worried about infection. And so we really don't want you to ignore this. You want to have that checked out because it can be a very serious infection. Increased pain, increased uterine pain. Your pain should not get worse. It should continue to get better. So if you're having pain that's getting worse, that would be a reason to call your doctor. Heavy bleeding. So your bleeding is worse than it was. It's increased or changed. That would be a reason to call the doctor. Pain or burning with urination. So we're worried about a urinary tract infection. A lot's going on down there. So definitely have that checked out. You might need to get on some antibiotics. A lump or hard area or red or painful area on your breast. So that would also be a reason that your doctor would need to look at that. Red, tender, or painful area on your leg. So that would be something we're concerned about, a blood clot. So again, another reason. Or anything that you just don't feel like. Or also you just don't feel like you're back to yourself. That would be a reason to call your doctor. You can always talk to your doctor at your OB office. about, you're just, you can't get back to your normal self, you're having a lot of anxiety, those type of things. Kind of along that line, so what's normal? So baby blues, they're pretty normal. They last usually, maybe the first 1 to 2 weeks. Mom is just, she might cry because she, doesn't know why. You might have trouble concentrating, those kind of things. So those are baby blues. And that should go away. You should start to feel like yourself after, 1 to 2 weeks after delivery. You're going to be tired, of course, but as far as feeling like yourself, you should start to feel like that. When it starts to get into the next level is when you have excessive worrying or anxiety. You're unable to sleep because you're so concerned or anxious about something. And it can be even that you're concerned about the baby. You're just worried something will happen to them. If you're unable to sleep, I always tell people if you're unable to sleep and you're unable to eat, that's not normal. A postpartum mom should be very tired, should be able to sleep anywhere, and should be hungry. Her body's healing, and it needs that nutrition. So those would be 2 major red flags that you would really want to pay attention to. Or anytime you're having thoughts of harming yourself and your baby. So the women that I've talked to that have had this, they knew that it wasn't right, but they still would have these outlandish thoughts, and they knew it wasn't right. So they, reach out and get help. It is okay to reach out and get help. All right, so get support. So have support, have people help you. Sleep when the baby sleeps, the house will be there. The mess will stay. The laundry will be there. It's okay. Those things, you need to take care of yourself first. You need to eat and eat healthy and stay hydrated. And of course, take care of yourself and be supportive of each other. Simplifying your life as much as you can, limit, well, right now it's very easy because we're limiting all outside obligations. And again, I talked about making your housework a lower priority. And we are limiting visitors, so that kind of helps to simplify our lives a little bit. All right. Let's talk about, sorry, I didn't mean to click past that. So intimacy. So things to know about is that you can ovulate before you actually have your first period. So we tell you after delivery, nothing in the vagina for 6 weeks. So that is no sex, no tampons, no douching. So, and then you're going to have a doctor's office appointment visit, and then they're going to release you at that time for those things. So make sure that you follow that. You can get pregnant before you go back to the doctor's office, and it has happened and we have seen it. So just know that that can happen. All right, just kind of a reminder, unless you want to come right back, but most people want a little bit of a break. All right, so here's before and after. Here we go. All right, so that is it. Thank you guys for listening. Hopefully you're able to make it through, or at least get through the major points. Here is my email address if you have any questions. Also on our website, there is a nice video that shows things about our unit. And if you haven't pre-registered, please call this number 792-7229 and get signed up for your pre-admission visit so that we can get all of your information and you don't have to do that when you come in labor. Again, thanks for listening, and you guys have a good day.